We welcome all our esteemed guests and expert panel members for our CME today regarding World Stroke Day, which is observed worldwide on the 29th of October. The theme for this year's World Stroke Day is Be Greater Than Stroke. That is channeling the emotional power of sport to drive stroke awareness and to motivate us all to take action every day to reduce our stroke risk. By taking action as a global community, we can be greater than stroke. We would like to warmly welcome our chairperson for today's session, Dr. Nadir Ali Sayed, who is a diplomat of the American Board of Psychiatry and Neurology, the American Board of Electrodiagnostic Medicine, and is currently practicing at South City Hospital, Karachi. We would also like to welcome our co-chairperson for today's session, Dr. Mohammad Shahid Mustafa. He was a board-certified consultant neurologist and diplomat, American Board of Psychiatry and Neurology, diplomat, American Board of Electrodiagnostic Medicine. He is currently practicing at NeuroCare, Karachi. We are also thankful to Dr. Salma Haji, Associate Professor of Neurology at JPMC, Karachi, for her efforts in arranging this session as a moderator. We will begin our program today with the name of Allah, the most beneficent and the most merciful. I would like to call Dr. Aman upon the stage to recite a few verses of the Holy Quran for us.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم ألم تر كيف فعل ربك بأصحاب الفيل ألم يجعل كيدهم في تضليل وأرسل عليهم طيرا عبابيل ترميهم بحجارة من سجيل فجعلهم كعصف مأكول صدق الله العلي العظيم.
I would like to invite our first guest speaker, Professor Dr. Abdul Malik, who is a renowned name in the field of neurology and the president of Pakistan Stroke Society.
Bismillahirrahmanirrahim. Bismillahirrahmanirrahim. On behalf of Pakistan Stroke Society and Department of Neurology, Jinnah Postgraduate Medical Centre, I would like to welcome you all. ये बेसिकली मेरा तो पेरेंट डिपार्टमेंट है और मुझे आप यकीन करें बहुत खुशी भी है कि आज इस प्लेटफॉर्म से I really thankful to Dr. Khalid Sher, who is also mentor, teacher of all the postgraduate, and he developed this department. You all seen by your own eyes, and जो यहाँ post graduation कर रहे हैं वो ख़ुद भी इस चीज़ का एहसास कर सकते हैं कि ये पूरा एक बहुत बड़ा ट्रांसफॉर्मेशन का अमल है जो इस डिपार्टमेंट ने अडॉप्ट किया है. आज जो ये CME है, ज़ाहिर सी बात है ये बहुत लोग कहते हैं कि मतलब ये हम डेज़ क्यों मनाते हैं और बहुत सारी एक्टिविटीज़ क्यों करते हैं. असल में ये जो एडवोकेसी है ये एक इंतहाई इम्पॉर्टेंट वर्ल्ड वाइड एक एलिमेंट है. अगर हम एज ए न्यूरोलॉजिस्ट, एज ए डॉक्टर, एज ए ट्रेनी, एज ए कंसल्टेंट, एज ए स्पेशलिस्ट ये काम नहीं करेंगे अपनी प्रैक्टिस में तो हम अपनी फील्ड को एक तरह से समझ लें कि बहुत ज़्यादा डेवलप नहीं कर पाएंगे. अगर न्यूरोलॉजी बहसीत फ़ील्ड एक डेवलप हुई है तो इसमें दुनिया भर में एक बहुत बड़ा एडवोकेसी का रोल है. और आज अगर पाकिस्तान के अंदर ये प्रॉब्लम है कि जो स्ट्रोक इंटरवेंशन है या स्ट्रोक की जो आगे की जो जैसे कहते हैं इंटरवेंशनल प्रोसेस, वो अगर कोई और फील्ड अडॉप्ट कर रहा है तो हमें उस पर अपनी एडवोकेसी के हवाले से कमज़ोरी का एहसास करना चाहिए. और हमें चाहिए एज ए फैकल्टी, एज ए स्पेशलिटी इस बात को बहुत स्ट्रांगली करें कि भाई स्ट्रोक इज़ प्योर डोमेन ऑफ न्यूरोलॉजी स्पेशलिटी और इसको लीड जो करेगा वो न्यूरोलॉजिस्ट करेगा. दैट्स वाई वी सेलिब्रेट, दैट्स वाई वी यानी उसको एक तरह से अवेयरनेस करते हैं, एडवोकेसी करते हैं हर डिज़ीज़ के हवाले से, ताकि जो इस हवाले से बात हो वो कम्युनिटी. और आप जो लोग अभी समझ बड़ी फिजिशियन हैं जो ये लोग वो ये बात जानें कि ये इंतहाई इंपॉर्टेंट चीज़ है. सिर्फ प्रैक्टिस कर लेना, मरीज़ देख लेना ये काम नहीं है. दुनिया भर में एडवोकेसी एक बहुत इंपॉर्टेंट कंपोनेंट है. दुनिया की जितनी बड़ी सोसाइटी, अमेरिकन एकेडमी ऑफ न्यूरोलॉजी है, यूरोपियन एकेडमी ऑफ न्यूरोलॉजी है, दीगर जो है उन सब में ये बहुत इंपॉर्टेंट कंपोनेंट है. लिहाजा ये हर बंदे के करने का काम है. और एक मैं छोटा सा ग्लिम्स करके अपनी बात करके आगे इस प्रोसीड करेंगे. चलो नेक्स्ट ये चले. नेक्स्ट, एडवोकेसी। बेसिकली एडवोकेसी जो एक एक्टिविटी है जो एक इंडिविजुअल भी कर सकता है, एक कलेक्टिव फोरम भी कर सकते हैं। यानी ये किसी मतलब सिर्फ सोसाइटी का काम नहीं है, सिर्फ किसी कलेक्टिव विजडम का काम नहीं। इंडिविजुअल आदमी, आज तो हर आदमी के पास मोबाइल है, वो बेहतरीन एडवोकेसी कर सकता है, उसको पॉजिटिव यूज़ कर सकता है। तो लिहाजा ये एडवोकेसी जो है ये इंडिविजुअल और ग्रुप के करने का काम है जो बुनियादी तौर पे डिसीजन मेकिंग में हेल्प करता है। अगर जिसे उर्दू में कहते हैं ना रायम्मा हमवार करना, रायम्मा हर चीज़ में हमवार की जाती है। आप कम्युनिकेट हर लेवल पे करते हैं, अगर हर लेवल पे कम्युनिकेट नहीं करेंगे तो बात आगे पहुंचेगी नहीं। और बात पहुंचाने का जो सलीका है, जो ढंग है, वो हम सबको एज ए स्पेशलिटी अख्तियार करना चाहिए। इसको ब्रॉड टर्म्स में देखें, जितनी भी स्पेशलिटी डेवलप हुई हैं वो थ्रू एडवोकेसी हुई हैं, थ्रू स्पेशलिस्ट डेवलपमेंट हुई हैं। जहां मरीज़ों की इंफ्रास्ट्रक्चर की अहमियत है, वहाँ इस बात की भी अहमियत है कि लोगों में, फिजिशियन में ये बात अवेयरनेस की जाए, अटेंशन दिलवाई जाए, उनको इन्फॉर्मेशन दी जाए, उनकी नर्सिंग की जाए, ताकि सपोर्ट टू इम्प्रूव द आउटकम ऑफ द पेशेंट। एट द एंड ऑफ द डे वी आर ऑल फॉर द वेल बींग ऑफ द पेशेंट। अगर हम वेल बींग ऑफ द पेशेंट के हवाले से काम नहीं करेंगे तो वो काम मरीज़ के हवाले से भी सफ़र होगा, ओवरऑल सोसाइटी के हवाले से भी सफ़र होगा। और अगर एडवोकेसी कैन बी वैल्यूएबल फॉर स्ट्रोक, अगर हम स्ट्रोक के हवाले से सिंपल बात करें तो प्राइमरी प्रिवेंशन, देखिए हम एक महदूद आमदनी वाले लोग हैं, गुर्बत हमारे यहाँ तमाम सेक्टर्स में पाई जाती है, उम्रा जो डिफरेंट है। लिहाजा हमें इस बात का एहसास रखना चाहिए कि हमें हर सूरत अपनी प्राइमरी प्रिवेंशन के हवाले से एज फार एज स्ट्रोक इज़ कंसर्न या दीगर डिजीज़ का उस पर बहुत ज़्यादा फोकस करना चाहिए। अपने हर मरीज़ को इस हवाले से गाइड और टीच करना चाहिए। नेक्स्ट, अब देखें इसके थोड़े से अदाद शुमार हैं जो मैंने जमा किए हैं। पाकिस्तान में कोई बहुत नो डाउट पिछले 10 सालों में बहुत सारी डेवलपमेंट हुई है, लेकिन इस वक्त टिल मई 2024 तक 370-375 के करीब FCPS न्यूरोलॉजिस्ट हैं। तकरीबन 20-25 के करीब, या अभी जो आज सुबह जो ये डेटा हेल्प आउट करते हैं उन्होंने कहा तकरीबन 30 के करीब MD न्यूरोलॉजिस्ट हैं, 90 के करीब DCNs हैं। 24 करोड़ से ज़्यादा की आबादी है, तो आप इससे अंदाज़ा लगा लें ये कितने पे डिवाइड होते हैं, स्पेशलिस्ट कैडर, कंसल्टेंट कैडर उसका। और स्ट्रोक यूनिट ये ओवरवेलमिंग पिछले 2 सालों में ये नंबर्स बढ़े हैं। अगर मैं 2022 का डेटा आपसे शेयर करूं तो 2022 में ये 47 नहीं थे, 10 के करीब स्ट्रोक सेंटर थे। ये नो डाउट जब से TPA आया है थोड़ी कॉस्ट चीज़ें बेहतर हुई हैं पब्लिक सेक्टर और प्राइवेट सेक्टर के अंदर, और ख़ास तौर पे पंजाब में। और यहाँ मैं पब्लिक सेक्टर इंस्टीट्यूट की यानी डॉक्टर खालिद भी बैठे हैं, मैं उनसे रिक्वेस्ट करूँगा कि प्रिवेंशनल स्ट्रोक यानी कंट्रोल प्रोग्राम पंजाब में बहुत ज़बरदस्त चल रहा है, और वहाँ 16 पब्लिक सेक्टर हॉस्पिटल हैं जहाँ फ्री TPA मिल रहा है। तो इस चीज़ को सिंध के अंदर हमें थ्रू एडवोकेसी, थ्रू सपोर्ट स्टार्ट करना चाहिए। और CT MRI तकरीबन 250-300 के करीब पाकिस्तान में है, और रिहेबिलिटेशन सेंटर जो है ज़्यादातर कोई इन पेशेंट के वाइज तो है नहीं, बहुत कम ही एक आध होगा, लेकिन तकरीबन यानी 200 के करीब हैं जो कि 4000 DPT हैं जो कि पूरे मुल्क में होम बेस या आउट पेशेंट बेस ही ये प्रैक्टिस करते हैं। नेक्स्ट, अच्छा GP अवेयरनेस भी बहुत ही पैथेटिक है, बहुत ज़्यादा लोगों को इसके साथ जो फास्ट साइन है, जो यानी कि फेस है, आर्म है, स्पीच है और टाइम इज़ ब्रेन के वाला मामला है, इसकी अवेयरनेस जो एक स्टडी गो के पुरानी स्टडी है उसके मुताबिक 45% थी, अब ज़्यादा 50% हो गई होगी। रिस्क फैक्टर अवेयरनेस भी 60% थी और रिस्क फैक्टर इंटरवेंशन 40% है। और नो ट्रेनिंग ऑफ स्ट्रोक ट्रीटमेंट एंड ख़ास तौर पे प्राइमरी प्रिवेंशन के हवाले से GP की जो नॉलेज है वो बहुत महदूद है, और नीड ऑफ ट्रेनिंग तकरीबन इसकी 95% है ताकि उनको प्रॉपर्ली अवेयर भी किया जाए। नेक्स्ट प्लीज़। ये ओवरऑल जो स्टैटिस्टिक्स हैं जो पूरी दुनिया में इस वक्त जो रिसेंट वर्ल्ड स्ट्रोक ऑर्गेनाइजेशन ने जो दिए हैं, तकरीबन 101 मिलियन पीपल आर लिविंग विद स्ट्रोक आफ्टर दैट, 101 मिलियन, और तकरीबन 12.2 मिलियन न्यू स्ट्रोक होते हैं एवरी ईयर, और तकरीबन 90% ऑफ ऑल स्ट्रोक आर लिंक टू 10 मॉडिफाइबल रिस्क फैक्टर। दिस इज़ वेरी इंपॉर्टेंट पॉइंट, यानी 10 मॉडिफाइबल रिस्क फैक्टर के नतीजे में जो आगे हमारे स्पीकर्स बताएंगे आप स्ट्रोक की प्रिवेंशन 90% कर सकते हैं। इसके अलावा हम में से बैठा हुआ हर 4 में से एक आदमी को ज़िंदगी में कभी भी कहीं भी फालिज हो सकता है। और इसके अलावा ये पाकिस्तान के अंदर जो अदाद शुमार है जो मुख्तलिफ हॉस्पिटल, नॉट कम्युनिटी बेस्ड, हॉस्पिटल बेस्ड जो स्टडीज़ में हुआ है वो ये है कि में से 250 स्ट्रोक होते हैं, यानी 1000 न्यू डेली स्ट्रोक हैं, और सालाना 3 से 4 लाख के करीब फालिज होता है जो पूरे मुल्क में। जो कितने लोग न्यूरोलॉजिस्ट ट्रीट करते हैं आप मुझसे बेहतर जानते हैं, कितने लोग फिजिशियन ट्रीट करते हैं आप मुझसे बेहतर जानते हैं, उनका क्या आउटकम है, वी ऑल नो वेरी वेल। नेक्स्ट, पाकिस्तान स्ट्रोक सोसाइटी इसकी ऑफिशियल बॉडी है जो पाकिस्तान में गुज़श्ता तकरीबन 2 से ढाई डिकेड से काम कर रही है, और हमारे बहुत सीनियर्स ने इसमें बड़ा रोल प्ले किया है। इस डिपार्टमेंट ने बहुत इंपॉर्टेंट रोल प्ले किया। डॉक्टर शौकत इसके प्रेसिडेंट भी रहे हैं, और इसके अंदर डॉक्टर हसन अजीज़ इसके प्रेसिडेंट हैं। बहुत सारे लोगों ने अपना रोल प्ले किया है, और अब भी पाकिस्तान सोसाइटी ऑफ न्यूरोलॉजी में डॉक्टर खालिद वाइस प्रेसिडेंट है। तो जो रोल प्ले हो सकता है वो अपनी तय कोशिश हो भी रही है, और हर 2 साल में ये होता है। और इसकी डेवलपमेंट ये है कि एकेडमिकली वो कॉन्फ्रेंस जो पहले एक्यूमुलेट होती थी 1-2 पेपर्स में, अब 3 दिन की फुल फ्लैज कॉन्फ्रेंस होती है। और हम आप तमाम लोगों से गुजारिश करेंगे कि अगले साल नेशनल कॉन्फ्रेंस है पाकिस्तान स्ट्रोक सोसाइटी की, 12th नेशनल स्ट्रोक कॉन्फ्रेंस, उसमें आप अपने पेपर्स, अपना रिसर्च वर्क ज़रूर उसमें पार्टिसिपेट करें। नेक्स्ट, की पॉइंट से बस मैं ग्लिम्सेस क्या दी, स्ट्रोक प्रिवेंशन, स्ट्रोक रिकग्निशन, नेक्स्ट स्ट्रोक सर्विसेज और लाइफ आफ्टर स्ट्रोक। इस पे फोकस करने की ज़रूरत है। अपने मरीज़ को इन 4 पैमानों पर नापने की, इन 4 पैमानों पर तोलने की, इन 4 पैमाने पे एग्जीक्यूट करने की ज़रूरत है। नेक्स्ट, ये वो चैलेंजेस हैं जो हम सबको इस सोसाइटी में फेस हैं। नंबर 1, अवेलेबिलिटी ऑफ इंफ्रास्ट्रक्चर। ठीक है, ये हम पाकिस्तान के सबसे बड़े शहर में हैं, लेकिन इंफ्रास्ट्रक्चर का जो हाल है हम सबके सामने, ये बहुत बड़ा चैलेंज है। नंबर 2, एक्सेस ऑफ स्ट्रोक सर्विस। कितने लोगों को रूरल एरिया में स्ट्रोक सर्विस, जो हम कहते हैं टाइम इज़ ब्रेन, 3 से 4 घंटे में कितने लोग पहुंच पाते हैं? कितने लोगों को ये बात का इल्म है कि 3 से 4 घंटे में ट्रीटमेंट हो जाए तो उसमें बेहतरी आ सकती है? कितने लोगों को वो एक्सेस हासिल है? कितने लोगों को वो प्राइमरी प्रिवेंशन के हवाले, ह्यूमन रिसोर्स कितना है? ये स्ट्रोक सेंटर का इंफ्रास्ट्रक्चर ऊपर मौजूद है, लेकिन ह्यूमन रिसोर्स जो ट्रेंड है जितना होना चाहिए उसकी बहरहाल इस वक्त कहते रिजाल है। बहुत ज़्यादा इसमें डेवलपमेंट की ज़रूरत है। इसके अलावा कॉस्ट ऑफ ट्रीटमेंट, दिस इज़ वेरी वेरी इंपॉर्टेंट। हमारे मुल्क में हम लोग आउट ऑफ पॉकेट ज़्यादातर लोग देते हैं, और जो हाल है 80-90 हज़ार का एक इंजेक्शन टीपी अगर है, बाकी ट्रीटमेंट है, दिस इज़ वेरी कॉस्टली। तो लिहाजा रिहेबिलिटेशन, कम्युनिटी सपोर्ट और अल्टरनेटिव मेडिसिन की भी बहुत सारे हैं। लिहाजा हमें प्राइमरी प्रिवेंशन के हवाले से बेइंतहा एडवोकेसी करनी चाहिए, उसको लोगों को गाइड करना चाहिए, उनको बताना चाहिए। नेक्स्ट, ये इस साल की कैंपेन है, इस पर मैं ज़्यादा बात नहीं करूँगा। नेक्स्ट, सिर्फ थीम पे बात करता हूँ। थीम इस साल की यह है कि फ़िज़िकल एक्टिविटी, ख़ास तौर पे स्ट्रोक स्पोर्ट्स रिलेटेड एक्टिविटी। वर्ल्ड स्ट्रोक ऑर्गेनाइजेशन ये कहती है कि जितना आप फिज़िकली मोबाइल होंगे, जितना ज़्यादा फिज़िकली एक्टिव होंगे, जितना ज़्यादा फिज़िकली कम्युनिटी में रिलेट करेंगे, उसी लिहाज से आपका ब्लड प्रेशर, शुगर, दीगर चीज़ें एक्टिविटी की बुनियाद पर बहुत बेहतर हो सकता है। नेक्स्ट, तो इसके हवाले से जो 2024 में प्रायोरिटी थीम है वो फ़िज़िकल एक्टिविटी है। नेक्स्ट, ये हम गुज़श्ता तकरीबन मतलब मुझे अब तकरीबन 25 साल तो हो गए हैं इस काम को करते हुए, और पाकिस्तान में पहला स्ट्रोक डे भी इसी डिपार्टमेंट ने शुरू किया था। ये इसमें एक 2007 का या 5 का है, जिसमें डॉक्टर शौकत उस वक्त हेड थे, और उस वक्त से हम ये मुख्तलिफ हर साल हम पूरे मुल्क में कुछ न कुछ कर रहे होते हैं। नेक्स्ट, ये हमने एक मॉडल तरतीब किया। नेक्स्ट, कि जिसके अंदर छोटे शहरों के अंदर अवेयरनेस और बहुत सारा काम किया जा सकता है रिस्क फैक्टर की बुनियाद पे, प्राइमरी प्रिवेंशन की। नेक्स्ट, ये बहुत सारी एक्टिविटीज़ हैं जो की जा सकती हैं, जिसमें ब्रांड है, जिसमें आप वेबसाइट पे, सोशल मीडिया पे साउंड बाइट्स बना सकते हैं, अपने खुद एक इंफॉर्मेशन। लोग हमने सिंधी लैंग्वेज में बहुत बड़े पैमाने पे पिछले 3-4 सालों में लोकल इंटीरियर सिंध में लिटरेचर को और वीडियो मैसेज को आप लोगों में जो लोग इंटीरियर के हैं उनको चाहिए अपने लोगों को कम्युनिकेट करें, एजुकेट करें इसके बारे के। कबूतर लगा देते हैं, बहुत सारी चीज़ें कर लेते हैं, इन सब मिथ्स के हवाले से आगाही पैदा करें। नेक्स्ट, ये बहुत सारी एक्टिविटीज़ हैं, लिटरेचर डेवलप किया है। नेक्स्ट, ये हमने एक स्ट्रोक मैनिफेस्टो बनाया था कि पाकिस्तान में स्ट्रोक की केयर के हवाले से क्या कुछ होना चाहिए। वो हमने 2000 तकरीबन 14-15 में ये लॉन्च किया था और तमाम मुतल्लिका इदारों को ये भेजा था। नेक्स्ट, तो इम्पोर्टेंस लैंडमार्क क्या है जो हम समझते हैं कि इस सेशन में जो 2026 तक एंड करेगा, कि हम चाहते हैं कि फास्ट की अवेयरनेस ज़्यादा हो। ये जो एक्रोमेन है, फेस, आर्म, स्पीच और टाइम, और स्ट्रोक यूनिट पब्लिक सेक्टर में एटलीस्ट 50 के करीब हो। हम इसमें कम्युनिकेशन भी कर रहे हैं बहुत सारे HOD से, जो फैकल्टी हैं, जिनको रिक्वेस्ट कर रहे हैं। इसके अलावा TPA की अवेलेबिलिटी और उसकी प्रॉपर जुडिशियस यानी यूटिलाइजेशन और थ्रोम्बेक्टोमीज़ की प्रॉपर उसके हवाले से एक्रीडेशन का काम, उसकी सर्टिफिकेशन के काम पे हम काम कर रहे हैं। हमारे जो स्ट्रोक स्पेशलिस्ट हैं मुख्तलिफ डिपार्टमेंट्स में। इसके अलावा हम चाहते हैं कि एक नेशनल मल्टी डिसिप्लिनरी स्ट्रोक टास्क फोर्स हो जो इंशाल्लाह सीनियर न्यूरोलॉजिस्ट पर मबनी, हम इसको डेवलप करने के प्रोसेस में, जो बहुत जल्द हम बाय द एंड ऑफ 2024 हम कोई ना कोई फॉर्म कर लेंगे। नेक्स्ट, तो ये फ्यूचर टारगेट हैं कि हमारा इसमें मेन टारगेट ये है कि डिस्ट्रिक्ट हेल्थ क्वार्टर हॉस्पिटल DHQ हॉस्पिटल तक स्ट्रोक की स्पेशलिटी और स्ट्रोक की सर्विसेज एक्वायर इस मुल्क में होनी चाहिए, और इसमें हम सबको अपना रोल अदा करना चाहिए, किसी एक के करने का काम नहीं है। नेक्स्ट, तो बेसिकली इस बात को फैलाने की ज़रूरत है कि फालिज बुनियादी तौर पे ब्रेन अटैक है। दिस शुड बी रिटन इन एवरीवेयर। जैसे हार्ट अटैक, आप देखें, मैं कहना नहीं चाहिए बीमारी को, लेकिन हार्ट अटैक को लोग बड़े ग्लैमराइज करते हैं, मुझे दिल का दौरा हुआ है, तो भाई दिमाग का भी तो एक अटैक है ना, ब्रेन अटैक। तो स्ट्रोक इज़ अ ब्रेन अटैक। तो इससे बचाव और इसको बताना, इसकी आगाही करना बहुत ज़रूरी है। नेक्स्ट, तो कंक्लूजन ये है कि एडवोकेसी इज़ द ओनली वे टू चेंज थिंग्स। हाई बर्डन ऑफ स्ट्रोक एंड रिस्पेक्ट इंक्रीजिंग ट्रेंड है। क्रिटिकल मास ऑफ मोमेंटम अवेलेबल टू मूव WHO स्ट्रोक एजेंडा फॉरवर्ड। वी आर स्ट्रगलिंग इन लिमिटेड रिसोर्सेज, और लॉन्ग टर्म स्ट्रेटजिक प्लान जिसको बनाने की ज़रूरत है, जिसमें कैलिब्रेशन के ज़रिए सिनर्जाइज होकर काम करने की ज़रूरत है। नेक्स्ट, ये साल की थीम का पोस्टर है जो आप सवाल इंशाल्लाह डिपार्टमेंट में मिल भी जाएगा। नेक्स्ट, तो गेट एक्टिव सो डैट वी यानी ग्रेटर दैन स्ट्रोक। थैंक यू वेरी मच। और आज की ये मैं गुफ्तगू कल 7 अक्टूबर को जो आलमी बहुत बड़ी दहशतगर्दी इजराइल कर रहा है, और उन मुजाहिदीन के नाम करता हूँ जो हमास और हिजबुल्लाह के तहत दुनिया की सबसे बड़ी ऑर्गेनाइजेशन इसके ख़िलाफ़ जो कर रहा है, ये आज की मेरी गुफ्तगू उन मुजाहिदीन, उन शहदा के नाम है। बहुत शुक्रिया।
Thank you, Dr. Abdul Malik, for such an informative talk. The control of risk factors is extremely essential in any disease prevention. So for our next talk on risk factors control in stroke, I would like to invite on stage Dr. Mariam Javed, who has done her fellowship in neurovascular medicine and is currently working as a senior registrar in the Department of Neurology, Dow University of Health Sciences, Karachi. Now I would like to invite
तीनों को बुला लें, तीनों को, सर को भी, डॉक्टर खालिद को भी,
We warmly welcome our chairperson for today's session, Dr. Nadir Ali Syed, who is a diplomat of the American Board of Psychiatry and Neurology, the American Board of Electrodiagnostic Medicine, and is currently practicing at South City Hospital, Karachi. We would also like to welcome our co-chairperson for today's section, Dr. Mohammad Shahid Mustafa, who is a board-certified consultant neurologist and diplomat of American Board of Psychiatry and Neurology, diplomat American Board of Electrodiagnostic Medicine, and he is currently practicing at NeuroCare, Karachi. We would also like to welcome our very own head of department, Dr. Khalid Sher, Professor Khalid Sher, who is the vice president of Pakistan Stroke Society. Now we'll continue our session. We would like to call upon stage for the next talk on control of risk factors in stroke. I would like to call Dr. Mariam Javed, who has done her fellowship in neurovascular medicine and is currently working as a senior registrar in the Department of Neurology at Dow University of Health Sciences, Karachi.
Hello. Assalamu alaikum. My name is Dr. Mariam Javed. I am currently working as SR in stroke medicine at Dow University, Oja. So it's so good to see a houseful audience. First of all, I would like to extend my gratitude to Pakistan Stroke Society for inviting me as guest speaker in this auspicious event. It is indeed, sir, an honor to share the podium with my teachers and my supervisors. So for today's talk, the topic of discussion from my side is the management of risk factors in the secondary prevention of stroke. So main objective will be to discuss these risk factors on the basis of the guidelines. Recently in the year 2021, AHA has published an updated guidelines, particularly for the secondary prevention of stroke, highlighting all the important imminent risk factors. So we are going to discuss those guidelines. So we all know, we are familiar that stroke is the leading cause of long-term disability, and we cannot emphasize enough that with a stroke it brings so much of cognitive, financial, social, economical, health-wise challenges, not only on the patient, on the families, but also on a community level. The thing about a stroke is that we should always address and manage a stroke as a preventable disease. We can prevent it, and when we define it to be as a preventable disease, it then becomes our responsibility as a primary caregivers to do the maximum of our capabilities to prevent it in our society. So stroke care, it doesn't end when the patient leaves the hospital, it rather enters into a next level of care that should be carried out in our clinics and our OPD setups. So this is the data that has been taken from developed nations, और इसकी emphasis ये है कि if you closely read it, so this is a European study, this is Australian and New Zealand studies. These are the developed nations, and even with these developed nations, जहाँ पे we've got advanced medical techniques, a lot of researches have been going on. Even with these facilities, the annual risk of recurrence of a stroke is more than 10%. In like this is a European study which was conducted for a period of 10 years from 1995 to 2005. In the initial 5 years, the annual risk of a stroke was 18%, which then came down to 12% in the following 5 years. The Australian studies is also showing almost a similar data, that the annual risk of recurrence of a stroke was 11%, again more than 10 years, which then increases to up to 20% at an interval of 5 years. This is a Chinese study, and it is showing that the annual risk of Chinese population is around 12.5 years. And this is a very large meta-analysis, thousands cases थे, and they actually retrieved 26 studies in over a period of 22 years, जिसमें उन्होंने एक बहुत variable सा एक range दिया हुआ है for recurrence of stroke, and again these numbers are quite significant. तो ये slide दिखाने का मकसद ये था to emphasize कि we cannot put our guards down, and as the primary caregiver and physician we need to be very careful and very vigilant in order to combat and overcome this disease. So when we talk about secondary prevention, we know that antithrombotics, anticoagulants, these are the mainstay of the treatment of secondary prevention. But these risk factors, these are actually the big players जो कि इस disease की pathophysiology को develop कर रहे होते हैं, because stroke doesn't happen overnight, it's not a communicable disease. So ये जो big players हैं हमारे पास risk factors, इनको address करना it's very important. We all know that risk factors are divided into two main categories, modifiable and non-modifiable. With the non-modifiable, the risk of a stroke would remain constant. I mean, you cannot change it, you cannot do much about it. Age है, ethnicity है, gender है. So ultimately क्या होता है कि all the efforts are then directed towards the identification and correction of the modifiable risk factors. Again, modifiable risk factors are then divided into medical and behavioral risk factors.
Mike.
The starting risk factors, they are all medical risk factors, while the last four, they are the behavioral risk factors. So we are going to talk about these modifiable risk factor individually and learn and try to revise कि हमारी guidelines हमें किस हवाले से guide करती हैं. Hypertension, blood pressure, we all know that it is the single most important and independent risk factor for both ischemic and the hemorrhagic strokes. Studies suggest that patients who never had a stroke, for the primary prevention, अगर हम उनका blood pressure, if we try to manage and keep it below 10 millimeter of mercury than the baseline, तो उससे हम उस patient को 33% stroke होने से prevent कर सकते हैं. So this is the primary prevention. And then studies also suggest that for secondary prevention, if you are going to address and manage the hypertension, you can actually reduce the relative risk by about 25%. So ये बहुत important है to never miss the hypertension in your stroke patient and to correctly address it. Guidelines हमें ये बताती है कि it is a very strongly recommended that your patient who had a TIA or a stroke and he comes to visit you in your office, in your clinic, the BP goal should be less than 130 by 80. So 130 और 80 का उन्होंने एक target set किया है 2021 की guidelines ने, and this is on the basis of multiple randomized controlled trials, podcast, profess and respect, sprint, एंड देन वेरी इंपॉर्टेंट एक बड़ी सी मेटा एनालिसिस की थी जिसमें उन्होंने इंक्लूड किया था सैम्पल साइज ऑफ मोर देन 40,000. उनकी बेसिस के ऊपर उन्होंने कंक्लूड किया कि अ टारगेट मैनेजमेंट ऑफ हाइपरटेंशन टू अ टारगेट ऑफ लेस देन 130/80 इज बेनिफिशियल फॉर प्रिवेंटिंग दी अनदर stroke. The guidelines, they do not advocate a single drug regime. They say that it should be individualized, but they do advocate that use of thiazide, diuretics, ACE and herbs along with the management of hypertension, they also reduces the risk of secondary strokes. If a patient who had a stroke or a TIA but who was not diagnosed or known to be hypertensive, and when he visits to you in your substantial visits in the clinic and you find that bhai unka blood pressure is now getting up to 130/80, the guidelines suggest that it may be beneficial to start antihypertensive medications. So now the next important risk factor is lipid. Lipids के ऊपर बात करने से पहले की गाइडलाइन हमें क्या कहती है? Let's just have a look कि how do we classify the statin therapies? कि we classify statin therapies as high intensity, moderate and low intensity. With a high intensity statin therapy, our target, our aim is to reduce the LDL level of more than up to 50%. And to achieve this target, we need to start statins in a high dose, for example, atorva and rosuvastatin, in the doses of 40 to 80 or 20 to 40 respectively. Moderate intensity में हमारा target value है जो 30 to 49 होता है. Usually those patients जो कि high intensity statin therapies को tolerate नहीं कर पाते, for those we can advocate a moderate intensity statin therapy. और इसमें respectively जो हमारे पास statins की dose है, then they become reduced. Low intensity therapy में only one is advocated, simvastatin, and the goal is again is to reduce less than 30%. ये हमें कौन गाइड करते हैं कि how do we classify कि हमें किस पेशेंट को कौन सी statin therapy देनी है? So there is a online calculator that can help to predict who are the patients who are at a risk, who are at a very high risk of future atherosclerotic cardiovascular diseases. So any more than two major events like ischemic strokes or having a recent acute coronary syndrome in the last 12 months, a past history of an MI or a symptomatic peripheral arterial disease. Either two of these events or one major event associated with multiple high-risk conditions like age more than 65, familial hypercholesterolemia, history of a bypass, diabetes, hypertension, kidney disease and current smoking. So इसकी basis पे we then decide कि हमें किस patient को कौन सी therapy देनी है. अब गाइडलाइन जो स्ट्रोक के हवाले से एक्चुअली स्पेसिफिक है, the AHA guidelines, they were based upon these two main landmark trials, Sparkle and TXT. बड़ी पुरानी trials है ये, और Sparkle के जो studies थी, they actually gave us the value के in patients who had a stroke and TIA, in order to reduce the recurrence rate to prevent a secondary stroke, and जिनमें कोई और major cardiac sources नहीं है. We know that likely this stroke is coming because of the atherosclerosis. On patients में we need to start high intensity statin therapy with atorvastatin in a dose of 80 milligrams. TSC was the trial जिसने हमें target value of LDL जो है वो define करके दिया कि a target value of LDL less than 70 is found to be more beneficial in preventing stroke than the traditional जो हमारे पास values थे 90 to 110. For the monitoring purposes, the guidelines strongly suggest that we need to monitor the LDL levels within 4 to 12 weeks of period of time after initiating statin therapy or after changing the dose, and उसके बाद subsequently we need to follow it in a range of 3 to 6 months. तो इसमें हमें determine होता है कि हमारी statin therapy जो हमने start की है उसके साथ हम क्या वो target achieve कर पा रहे हैं नहीं कर पा रहे. So surveillance is very important regarding the management of this disease. Triglycerides, initially triglycerides were not directly associated having cerebrovascular, but since they are associated with cardiovascular, now the guidelines do merit its management of an optimal level of triglyceride. So the guidelines suggest that patients who had a stroke or TIA and they are coming with a moderate level of triglyceride not exceeding more than 500 with an LDL also relatively controlled, and already on moderate or high intensity statin therapy. For these patients you can start icosapent ethyl, which is basically omega-3 fatty acid. तो जिनके moderately elevated triglyceride उनके लिए जो guidance suggest करती है कि आप omega-3 fatty acid start कर सकते हैं in a dose of 2 grams twice daily. But जिनके triglycerides they are exceeding the level of 500 and who are at greater risk of not only stroke but also pancreatitis, for these lifestyle modifications with low fat diet, avoiding refined carbs and alcohol, consumption of omega-3 fatty acids, and now you need to initiate the fibrate therapy also. Diabetes, we know, very well known, well defined risk factor for any atherosclerotic, cardiovascular, cerebrovascular disease. So diabetes basically, diabetes part 1, diabetes type 2 and pre-diabetic state is basically glycemic control to have, but the patient is found to be insulin resistant, dissipation के issues हैं. Altogether they contribute towards the pathophysiology of the stroke. So for diabetes, the guidelines suggest that it is strongly recommended that the treatment for hypoglycemics they should be individualized. तो कोई एक general treatment नहीं है. Taking into accountability कि patient के क्या comorbidities हैं, हमें उसकी जो hypoglycemic management है उसको individualize करना होगा. However, for patients who are younger than 65 years of age with no known comorbidities that can actually decrease the life expectancy of that patient, it is recommended in order to prevent microvascular complications of diabetes, the HbA1c target should be less than 7%. Although कोई एक specific hypoglycemic name करके या quote करके guidelines में नहीं है, but we do advocate those hypoglycemic that have proven cardiovascular benefits as well, just like SGLT2 inhibitors and glucagon-like peptide-1 agonists, these are more favorable in order to manage the diabetes also in the patients of a stroke. Again, we need to have a multi-dimensional approach. We need to refer these patients to professional health, to nutritionists, to diabetologists, endocrinologists in order to maintain and achieve our target. For patients who are now pre-diabetic, it is recommended that we should start with the lifestyle optimization with regular physical activity, healthy diet, and of course, smoking cessation. With pre-diabetics, the guidelines also start these medications in pre-diabetics, provided that for metformin, the pre-diabetic should be if that patient is having a BMI of more than 35 with an age of 60 years, and particularly with women who had a history of gestational diabetes. तो ऐसे पेशेंट जिसके पास आपके पास क्राइटेरिया ये है कि वो BMI ज़्यादा है, फीमेल जेंडर विद हिस्ट्री ऑफ जेस्टेशनल डायबिटीज़, उनमें इट इज़ मेरिट कि आप उनकी अगर प्री डायबिटिक स्टेज पे है तो यू स्टार्ट मेटफॉर्मिन. According to the guidelines, HbA1c is a very simple and convenient, reasonable screening method to pick up diabetes. So the guidelines also suggest that patients who are more than 65 years of age and who had a who are 65 years of age, इनके पास कोई significant comorbidities हैं and they have already developed microvascular complications of diabetes. For these patients, the targeting the HbA1c to keep it below 7%, it has not proven to show a long-term benefit in the outcome in the morbidity. तो यहाँ पे जो एल्डरलीज हैं जिनको ऑलरेडी डायबिटीज की कॉम्प्लिकेशन हो चुकी है, तो हम थोड़ा सा लेवरेज ऑफ कन्वीनियंस दे सकते हैं. न्यूट्रिशन, सो न्यूट्रिशन प्लेज अ वेरी इंपॉर्टेंट रोल इन आवर जनरल फिजिकल एंड मेंटल वेलबींग. हम जो खाते हैं वही हमारे ऊपर इफेक्ट कर रहा है. वी कैन लीड आवर लाइफ अकॉर्डिंग टू दैट. जो भी फूड हम अपनी बॉडी को प्रोवाइड कर रहे हैं. सो फॉर द न्यूट्रिशन डिफरेंट टाइप्स के हमारे पास न्यूट्रिशन के रेजिम्स होते हैं. डैश डाइट है, then we have a Mediterranean diet. So the guidelines suggest that Mediterranean diet is more beneficial for patient to prevent the recurrence of a stroke. Mediterranean diet that we are going to discuss. So for those patients जो कि अपनी salt का intake completely restrict नहीं कर सकते हैं, they cannot adhere to a very good diet. For those patients, the guidelines say कि हम उनको at least ये counsel करें that we need to reduce their normal जो डोज वो ले रहे हैं सॉल्ट की या सोडियम की, उसका जो है ना वो हमें 1 ग्राम ऑफ सोडियम कम करना है. अभी 1 ग्राम ऑफ सोडियम क्या होता है? 1 ग्राम ऑफ सोडियम इज इक्विवेलेंट टू 2.5 ग्राम ऑफ सॉल्ट. और 2.5 ग्राम ऑफ सॉल्ट को अगर हम बहुत आसानी से समझाएं तो वो हाफ अ टेबल स्पून होगा. तो हमें उस पेशेंट को ऑब्वियसली हम फिजिशियंस हैं, हम जेलर नहीं हैं, हमें उनको काउंसिल इस तरीके से करना है कि स्लोली एंड ग्रेजुअली वो हेल्दी एक्टिविटीज़ को जो है वो अडेप्ट करें, हमें उनको डराना है। तो हमें उनसे इतना कहना है कि आप जितना नॉर्मल रोज़मर्रा में इस्तेमाल करते थे अपना सॉल्ट इंटेक, उसमें से कम जो है वो रेगुलरली ½ टीस्पून कम करते जाएं। तो इससे थोड़ी आसानी होती है और थोड़ा सा उनका मोराल भी बूस्ट होता है कि दे आर मीटिंग देयर प्राइमरी केयर नॉट अचीवर। अच्छा, सो मेडिटेरियन डाइट का जिक्र क्या था? व्हाट इज अ मेडिटेरियन डाइट? बेसिकली द मेन चंक ऑफ द मेडिटेरियन डाइट इज फॉर्म बाय द होल ग्रेन सीरियल्स एंड व्हीट। इसके अलावा मेडिटेरियन डाइट इट encourages the use of plant based food like vegetables, lentils, fruits. It encourages the use of seafood and fishes, and it actually advises to use olive oil as the main cooking medium. The use of poultry and dairy product should be a little bit moderate, इतना abundantly नहीं use कर सकते, and they need to avoid all the sugary stuff, all the red meat, processed meat and bakery items. So this is a very simple Mediterranean diet जिसको हमें अपने मरीजों को क्लिनिक में समझाना है कि आपने इस तरीके से चीज़ों का इस्तेमाल करना है और इस तरीके से फूड आइटम सेलेक्ट करना है। अच्छा, फिजिकल एक्टिविटी बहुत इम्पॉर्टेंट है। फिजिकल एक्टिविटी के बारे में ये हमें गाइडेंस बताती हैं कि our patients who had PIE or stroke and who are capable and willing to do a physical activity, so it is recommended a aerobic activity for a period of 10 minutes 4 times a week. हफ्ते में 4 दिन ले लें, उसमें से 10 minutes के लिए moderate intensity की exercises करेंगे। If the patient is not able to हफ्ते में 4 दफ़ा ये टाइम दे सके, so you can guide them to do a vigorous exercise for 20 minutes of time at least twice a week. For all these counseling and things, the guideline actually asks and recommend कि हम उनको जो है वो professional help के लिए भेजें. We send them to exercises, classes, groups and counseling, and they need to do these exercises under supervision of a rehab therapist. Because many times जो हमारे पास elderly patients आते हैं, they do come with a lot of hidden joint issues. तो हम एकदम से उनको डायरेक्टली गाइड नहीं कर सकते कि you start climbing up and down the stairs या start doing some vigorous exercises. They need to be at least screened first कि उनकी क्या क्या कैपेबिलिटीज़ हैं, उनकी क्या क्या लिमिटेशंस हैं, और उसमें गाइडलाइन हमें सजेस्ट करती है कि हम किसी थेरेपिस्ट का या प्रोफेशनल्स की हेल्प लें। अच्छा, those patients जो हमारे स्ट्रोक और TIA के पेशेंट्स हैं who cannot who sit for longer period of time and they sit idly uninterrupted, for those patients it is advised कि अपनी जो उनका रूटीन है उसमें से they at least take short breaks of 3 minutes after every 30 minutes roughly. तो 3 मिनट का जो है वो शॉर्ट ब्रीफ ब्रेक ले लें और उसके दौरान they need to mobilize themselves, they need या तो they keep standing या थोड़ी बहुत वॉक कर लें, और इस तरीके से वो for a longer period of time uninterrupted बैठे ना रहें, they mobilize themselves. तो ये कहने को बड़ी छोटी छोटी और कॉमन सेंस की बातें हैं, लेकिन यही बातें जब हमारे पेशेंट हमारे पास क्लिनिक में आते हैं ना, तो मैनी टाइम्स वी फेल टू कन्वे इट टू देम। जब तक वो खुद क्वेश्चन प्रोवोक ना करें, आइडियली ये होना चाहिए एज देयर फिजिशियन वी नीड टू टेल देम ऑन द वेरी फर्स्ट वी इस तरीके से दवाइयों के अलावा भी आप अपना रिस्क ऑफ स्ट्रोक को कैसे रिड्यूस कर सकते हैं। थोड़ा सा एक ग्राफिकल एक पिक्टोरियल प्रेजेंटेशन है कि लाइट एक्सरसाइजेस क्या हैं, मॉडरेट क्या है। हमारी जो वॉकिंग है या वी कैरी समथिंग और वी क्लीन आवर हाउस और वी डू अ योगा मेडिटेशन, दे कम अंडर द कैटेगरी ऑफ लाइट एक्सरसाइज। मॉडरेट में जो है ना वॉकिंग, साइकिलिंग, क्लाइंबिंग द स्टेयर्स अप एंड डाउन। विगरस एंड देन कम्स एक्टिवली टेकिंग पार्ट इन स्पोर्ट्स, डांसिंग एंड स्विमिंग। एंड वेरी विगरस में जिसमें हमारा बहुत ज़्यादा कार्डियो हो रहा होता है, दैट इज लाइक वेट लिफ्टिंग, पुशअप्स एंड डूइंग सम कार्डियो एक्सरसाइजेस। तो हमारे पास जो पेशेंट्स आते हैं, हम कोशिश करते हैं कि एटलीस्ट एक मॉडरेट लेवल ऑफ एक्सरसाइज फिजिकल एक्टिविटी हम उनको एक प्लान बना के दें, हमको उसके हवाले से काउंसल करें। ओबेसिटी BMI का डायरेक्ट रोल तो नहीं है, बट एक्चुअली जो वेस्ट टू हिप एंड वेस्ट टू हाइट के जो रेशियोज हैं, ये पैरामीटर्स ज़्यादा जो है वो इन्फ्लुएंस करते हैं फॉर हैविंग अ प्राइमरी और सेकेंडरी स्ट्रोक। ओबेसिटी के बारे में अगेन वेट लॉस इज रिकमेंडेड एंड इट इज स्ट्रांगली रिकमेंडेड, एंड फॉर दीज वेट लॉस ना सिर्फ हम उनको एज पर फिजिशियन गाइड करें, बट वी सेंड देम टू प्रोफेशनल हेल्प। It is very important, the last point, BMI calculation is recommended. This is an underestimated point, and even in our practice, we do not take into account जब हमारे पास patient clinics में आप admit हो रहे होते हैं कि उनका BMI क्या है. Although we do measure their weight, because at times हमें patients को if they fall under the category of fibrillary therapy हम उनको EPS देने होते हैं, but we fail to understand कि इसकी क्या importance है. BMI calculation बहुत easy है, कोई भी intern कोई भी physician कर सकता है. So it should be in the practice to screeningly check for BMIs when the patients in our admitted setup and when they also come for our OPD visits. अच्छा जी, OSA जो है वो डायरेक्टली या इंडिपेंडेंटली तो स्ट्रोक को इन्फ्लुएंस नहीं करता, बट इट चेंजेस a lot of the physiological changes कर रहा होता है, and that is how it indirectly causes the patient to have a stroke. So for patients जो हमारे पास स्ट्रोक के हैं, it is important कि अगर इंडिकेशन है तो we evaluate them for OSA, and if they are diagnosed with OSA, we should start them with a treatment with positive air pressure. तो ये पॉइंट मिस नहीं करना है जब हमारे पास स्ट्रोक के पेशेंट्स आते हैं कि जहाँ हम स्मोकिंग का क्वेश्चन करें, जहाँ स्मोक करते हैं नहीं करते हैं, तो वी शुड ऑल्सो टेक इनटू अकाउंट कि उनका BMI और उनके OSA की कोई रिस्क फैक्टर्स हैं कि नहीं. Definitely smoking a very important risk factor for having any kind of cardiovascular or cerebrovascular events, and strongly recommended कि हम उसको counsel करें to quit smoking. अगर वो फौरन से तो वो क्विट नहीं कर सकता है तो one step at a time to at least tell them to reduce the numbers of cigarettes that he smokes. So one step at a time, and then the all important point is passive smoking. Active smoking के लिए we are frequently asking questions, we are having hawk's eye, but even passive smoking is also playing a role in the development of a stroke. So we need to counsel them for avoidance of passive smoking too. तो अगर किसी ऐसे माहौल में है, उनको कुछ ऐसी arrangements करनी होंगी so that the patient is able to avoid passive smoking. Substance uses like alcohol, CNS stimulants, amphetamines, they all needs to be counseled regarding the cessation of using these substances. And it is strongly recommended कि जब हमारे पास इस किस्म के patients आते हैं, we refer them to specialized services and professional counseling centers where they can get professional help and able to avoid these substance abuse. So this was all about stroke risk factors. अब एक new term for the last couple of years emerged हुई है, that is known as stroke triggers. So many times the patient asks us that our patient was like he'd been hypertensive, he'd been diabetes for a very long time. Why now he's having this stroke? And बहुत दफ़ा हम उसको correctly address नहीं कर पाते कि अब क्यों इस phase of movement में उसको stroke हुआ. But there are certain defined stroke triggers, और इसको एक दूसरा नाम भी दिया गया recent literature में, that these are the short-term risk factors जिसमें infections or a state of inflammatory condition, sepsis, they also can trigger stroke in those patients जो कि susceptible हैं, जिनके पास at the background potential risk factors हैं. तो जब आपके पास पेशेंट्स सेप्सिस में या इन्फेक्शंस के साथ प्रेजेंट करते हैं एंड इट इज़ नॉट कॉन्ट्राइंडिकेटेड कि आप उनके एंटीप्लेटलेट ट्रीटमेंट को रोकें, तो इट इज़ प्रूडेंट इनफ टू कंटिन्यू विद द एंटीप्लेटलेट एंड सेकेंडरी प्रिवेंशन ऑफ द स्ट्रोक. Another very important risk trigger is air pollution. So in some literatures and some of our expertise have actually defined it as established risk factor. अभी तो हम यहाँ पे स्ट्रोक ट्रिगर के हवाले से बात कर रहे हैं, बट कुछ लिटरेचर में जो है उसको established risk factor of stroke करके भी define किया गया है. Although it has not found its way into the guidelines right now, but maybe in upcoming years we can see कि ये mention हो. So ये जो air pollution है, these are the suspension particulates in our atmosphere जो कि indirectly pathophysiologically clear नहीं है, it is under investigation and researches, but this in short अगर मैं अपनी ऑडियंस को एक बात कन्वे करना चाहूँ, ये कहूँगी कि to keep our atmosphere and our lungs clean, and even with this we can help in preventing stroke. So the take home message would be, my closing statement would be the same as my starting message, that take and manage stroke as a preventable disease. ये जो guidelines बनाई गई हैं ये local तो नहीं है, but these are the only guidelines that we can refer to. And these guidelines, they can give you an idea how to make a stroke protocol or a stroke pathway, but the treatment regime would then need to be individualized too. And vascular and behavioral, both of the risk factors, they need to be identified and managed equivalently. जस्ट एक आखिरी रिमाइंडर, सिंस वी आर सेलिब्रेटिंग स्ट्रोक डे, हम बहुत सारे किस्म के डेज डिफरेंट अपनी मेडिकल फ्रेटर्निटी जो है वो सेलिब्रेट कर रहे होते हैं. दीज डेज आर ऑल्सो अ रिमाइंडर टू आवर ओन सेल्फ कि ये जो स्ट्रोक की बात करते हैं, कार्डियोवैस्कुलर की बात करते हैं, इन आवर प्रैक्टिसेस वी सी सो मेनी पेशेंट्स डे इन एंड डे आउट, and we often forget that we ourselves are not immune to these diseases. हमें भी बीमारियां लाहक हो सकती हैं. तो जहाँ पूरा हमारा डिस्कशन आगे भी पेशेंट केयर के ऊपर एम्फसाइज करेगा, we also need to take care of ourselves, because very unfortunately in the last couple of years we have known very valuable physicians, surgeons, emergency care doctors. We have lost their life to diseases like stroke, cardiovascular disease and sudden cardiac arrest. और बड़ा frequently, repetitively in the last few years हमें ये देखने को मिल रहा है कि हमारे emails में, professional emails में condolences के messages आ रहे होते हैं. So this is very sad and it is not easy to miss that there is something wrong in the in our approach to our lives. So please kindly take care of yourself, take care of your families, set your priorities right. क्योंकि अगर आपने अपना ख्याल नहीं रखा तो कोई और नहीं रख सकेगा. तो इन सब चीज़ों के साथ ये नहीं भूलना है कि ये बीमारियां हमें भी लाहक हो सकती हैं. तो जो हम टीच कर रहे हैं, जो हम प्रीच कर रहे हैं, हमें उसको प्रैक्टिस भी करनी है. थैंक यू. So we will take questions in the end.
We are thankful to Dr. Mariam Javed for enhancing our knowledge about the risk factors control in stroke. We also welcome Professor Dr. Muhammad Ali, who is with us here, and we'll be having a talk with him shortly. As we all know that the best protection is early detection. For giving us more detailed information regarding the early signs of stroke and approach to a patient with transient ischemic attacks, I would now like to invite Dr. Inam Khuda, who has done his fellowship in neurovascular medicine and is currently working as an assistant professor in the Department of Neurology at Dow University of Health Sciences, Karachi.
Bismillahirrahmanirrahim. Assalamu alaikum. First of all, I would like to say that I really feel very much honored today to be here with all of you people, with the faculty in this institute that is one of the pioneer institutes of neurology in the country. And thank you very much to all of the faculty, especially Professor Khalid Sher and Professor Abdul Malik for inviting me over here. It's really an honor and very grateful to all of you people. I would like to start with my talk. Can I have these two things? Let's talk about neurology now. We've been talking too much about risk factors. We're going to talk about the presentation of a stroke and how to approach a phenomenon called as TIA, or transient ischemic attack. Stroke, basically, how I see stroke is basically it's a vascular pathology. It's a disease of the blood vessels, and stroke is a victim of that, whatever goes on in blood vessels. So if you want to determine the signs of a stroke, early signs of a stroke, you have to understand the vascular distribution of the brain. So most of the in the brain, the corticospinal tract fibers are very much widely distributed. So most of the stroke presents with a unilateral motor weakness. That is one of the most common presentations of a stroke. A unilateral motor weakness that involves face, arm and leg. But the actual total presentation depends upon which blood vessel is actually involved. I will not go into details of different syndromes that happen. When we talk about the vascular supply of brain, we all know that we divide into anterior circulation and the posterior circulation. And the anterior circulation is composed of the carotid arteries. There can be different syndromes that can happen when there's a pathology in the anterior circulation. Again, there will be unilateral motor weakness, but there's another thing called as cortical signs. If you find cortical signs, that means you might be dealing with an anterior circulation syndrome. We have many neurologists, many neurology PGs over here, don't we? So, can you tell me what are the cortical signs? Very good. Aphasia is one of the cortical signs that comes from dominant hemisphere. Any other cortical sign you can think about? Abulia, that comes from the anterior circulation, anterocerebral artery, yes. Apraxia, yes. Sorry? Agnosia. So as neurologists, we do go into those uncommon, but they can be, you should be able to diagnose them. The most easily identifiable cortical signs are aphasia. Then next is a hemi-neglect syndrome, a sensory neglect syndrome, or a visual field defect, that's hemianopia. And the fourth one is the gaze preference. So sometimes patients have a gaze preference towards one side. So if you find these cortical signs, there's a very high likelihood that you're dealing with an anterior circulation. There can be certain cortical signs that are found in posterior circulation strokes as well. But I'm emphasizing over here regarding cortical signs because the presence of cortical sign means there's a high likelihood of an LVO. We'll discuss about LVO later on. We'll discuss about the mechanical thrombectomies. LVO is a large vessel occlusion. Patients having large vessel occlusion that can be a target for a thrombectomy. They usually have cortical signs as well. So you should be able to determine whether the patient has cortical signs along with other signs as well. Posterior circulation syndromes, no good details, don't worry about this busy slide. I just want you to know there are many different syndromes within posterior circulation, but the most characteristic thing that we see in posterior circulation are cross signs. So cross signs is a phenomenon in which the patient would have an ipsilateral cranial nerve palsy and a contralateral descending tract sign. So the most usually comes in your MCQs, the patient has a unilateral lower motor neuron facial palsy and contralateral motor signs, contralateral corticospinal tract signs. So it's mostly where would you localize that lesion? अगर पेशेंट को किसी एक साइड पे लोअर मोटर न्यूरॉन फेशियल पैल्सी है और लेफ्ट दूसरी साइड पे जो है वो वीकनेस है, pontine lesion. A patient has a unilateral pain and temperature sensation loss and a contralateral limb pain and temperature sensation loss. Where would you localize that lesion? Very good, medulla. So that's the good thing while discussing this with the neurologist. So you will have other signs in that. You will have an ipsilateral cerebellar signs as well. So the main thing in the posterior circulation strokes is to have the cross signs. So this is not just about the signs. When you talk about stroke, it is the temporal pattern of those symptoms. So whatever the symptoms are, a unilateral motor weakness, a sensory loss, what's important to know is that how those symptoms started and how they have behaved over time. Vascular pathologies is an oversimplified graph, but it just shows you how the vascular pathologies they present. They usually have a very sudden onset, and then there's a plateau, and they do get better with time later on. So sometimes there's a sudden onset, but after a few minutes to hours, they completely go away. The symptoms completely go away. We call this phenomena as a TIA or a transient ischemic attack. We discuss this later on. So whatever the symptoms are, it's important to know the temporal pattern of those symptoms, how they started, whether they started suddenly or not. There are certain symptoms in which there can be a stuttering of the deficit initially, but then it maintains a plateau later on after a few hours. But that is the whole idea, that usually the patients having a stroke, they would have a sudden onset. That is the main challenge. So, a stroke is relatively very easy to diagnose. It's not a big diagnostic challenge. We can all people, neurologists or people who have got some idea about how the patients present, they can easily diagnose. The main challenge is to diagnose it early detection. And that challenge actually came up when almost 2 decades back, the reperfusion therapies, they were started, the IVTPA and later on the mechanical thrombectomy. So because they had a very limited, reperfusion windows, the window of treatment was very limited, 4.5 hours or 6 hours. So the challenge was how to detect stroke signs at the earliest possible moment. And what the people thought that it's better to diagnose them while they're at home. So they made those algorithms or these acronyms that can be used by any person who doesn't have any medical knowledge. If you can apply these algorithms, you can capture 70 to 80% of those strokes. So initially they started the FAST algorithm, called as face, arm and speech. So whenever there's a sudden weakness of face, certain weakness of arm strength, or certain speech problems. That any one of these could be a stroke until proven otherwise. Then they started the other mnemonic called as BFAST. That is, they also include the balance, sudden onset of balance symptoms, and certain vision problems to include the posterior circulation symptoms as well. So this BFAST algorithm captures nearly 70 to 80% of the strokes, and it has been very successful. The main thing is the time. So the T for time is the main problem, and how to to diagnose, to detect these BFAST symptoms. Any one of these symptoms, if they are there, that started suddenly, you have to take the patient as soon as possible to a nearby stroke center where this patient can be evaluated. So remember, this word time is brain. So that is the main issue. So what actually happens, that whenever there is a vascular pathology, a vascular insult to a part of the brain, the whole brain doesn't die. A very small core actually becomes irreversibly damaged. A very large penumbra is still salvageable. You can still save it if you can reperfuse that part of the brain. But that opportunity, you lose that opportunity by every minute. So every minute, nearly 2 million neurons, they die. So as you progress in time, this core, the ischemic core, increases in size, and in most of the patients, though not all of them, almost in 6 hours, the whole of the core is dead. So you have to move, you have to detect early all of the stroke signs and symptoms, and you have to have a system in your hospital, in your stroke center, where you can evaluate do the necessary evaluation and start with reperfusion therapy if the patient is eligible. So now we talk about the transient ischemic attack. Transient ischemic attack has two definitions. One of the definitions is the classical definition, that is the time-based definitions. As we discussed before, many times patients having a vascular pathology, they do have a complete recovery of all their symptoms within a few hours. By definition, whenever there is a complete recovery within 24 hours of a focal neurological symptom that is attributable to a decrease in blood flow, that we call it the transient ischemic attack. This is the most famous and most applied definition of TIA. However, it was found that many patients who have a complete recovery of symptoms within 24 hours, they may still have a small infarction in their brain. So they devised a tissue-based definition in which it is very simple. So there is a transient episode of neurological dysfunction that is not because of an acute infarction. So if you can exclude an acute infarction by doing different techniques like an MR scan or imaging technique or a tissue biopsy, that is all not feasible at most of the times. So if you exclude an infarction, then most likely you're dealing with a TIA. So important message over here is that TIA should be taken seriously. If the symptoms go away, that doesn't mean the trouble also has gone away, because many TIAs actually, if you look at this picture, this graph, a TIA, when it happens, it also increases the chances of having a catastrophic stroke, and that chance actually remains for next 90 days, for next 3 months. The highest chance is in the first 2 days. So if you look over here, the dashed line is for the TIAs, and the red line is for the risk of a stroke for the minor stroke. Have you heard about, what's minor stroke? How do you define minor stroke? Motor Rankin score. Any other? So there is a scale for stroke severity that we call as NIHSS. Any person who has a NIHSS of less than 6 or a non-disabling deficit is called as minor stroke. So if you have a patient who had a stroke-like symptoms, some symptoms have gone away, or still has very minimal subtle symptoms like this, just a pronator drift, for example, just a minor facial deviation, that doesn't mean the trouble is over. That means the patient is actually is possibly is at a high risk of having a major stroke within the next 2 days. So how to identify TIAs? Again, the same symptoms, usually the same. Patient will have a unilateral weakness, they can have a speech difficulty. A very classical TIA syndrome is called as transient monocular blindness or amaurosis fugax, which is a transient loss of vision in one of the eyes. So any of these syndromes that are relatable to a vascular territory that has completely gone away, that is called as, you can call them as typical TIAs. Now in clinical practice, you do come across many atypical symptoms, many symptoms that you cannot really say whether they're TIAs or not. So like an isolated vertigo or a double vision or isolated loss of balance that just remain over there for a few minutes or a few hours, or a slurring of speech that has completely gone away, or a bilateral decreased vision, or just a hemisensory loss that has gone away. So we call them as atypical TIAs. Now studies have shown that atypical TIAs it's better to treat them as a stroke as well. So it's better if the patient has risk factors for a vascular pathology, it's better that you do treat them as just like any typical TIAs. Whenever we talk about strokes, especially symptoms that have gone away, you should also consider the stroke mimics. A seizure, a focal seizure that can leave a patient with a post-atrial paralysis is a very common stroke mimic. Migraine with aura. Patients can have unilateral numbness. So if there's any history of headache along with the stroke symptoms, any syncopal attacks, transient global amnesia, peripheral vestibulopathy is a very common stroke mimic. Hypoglycemia, cerebral amyloid angiopathy mimic the TIA symptoms as well. So again, TIA can be a warning. Just remember this: high risk TIA and minor stroke, minor symptoms or subtle symptoms with NIHs of less than 6. How to know whether this TIA is likely to have a stroke? So there can be certain features in a TIA in a patient which can give you an idea that there's a high likelihood of having a major stroke. First of all, it's time since the event. As I told you that it is the first 48 hours, although the risk is there for next 3 months, but the first 48 hours, the possibility of having a stroke is much more in the initial few days. There's a thing called as ABCD2 score, that is the grading of a TIA. So we can have an idea about the stroke risk and the etiology, the pathophysiology of that particular stroke. That gives you an idea about the likelihood of having further strokes. So, as I told you before, after a stroke, after a TIA, the possibility of having a stroke varies, in different studies. But for the first 48 hours, can be up to 5%. The stroke risk is elevated for first 90 days, but 40% of all those strokes happen within the first 48 hours. Patients having extracranial carotid disease, they're very likely to have a preceding TIAs. Nearly 75% of these patients would proceed with a TIA. Next thing is the risk of a stroke of a TIA, called as TIA scale. We call it ABCD2 score. So it's a very commonly used TIA score, but its predictive performance is not that much satisfactory. Still recommended by American guidelines. In UK, Ireland, they are not recommended. They say TIA is TIA, whatever the risk, whatever the grading is. The score is as follows: is age. So we consider the age. Above 60 years, it's 1 point. A blood pressure of more than 140 over 90. The blood pressure should be measured immediately after the TIA. Clinical features: unilateral weakness increases the score. Isolated speech disturbance will give 1 point only. The duration of symptoms: the more prolonged symptoms are there, the higher the score is. And the presence or absence of diabetes. Presence of diabetes increases likelihood of having another stroke. So if the score is 6 to 7, there's a high risk of a stroke within the next 48 hours, almost up to 8%. If the score is 4 to 5, there's a moderate risk of 4%, and 0 to 3 it is low risk, almost 1%. How the vascular etiologies will guide you regarding the stroke risk. Large arterial sclerosis. If there is an ICA stenosis of more than 70%, there's a very high likelihood of having another stroke in the next 48 hours. If the patient has carotid webs or non-stenotic extracranial carotid disease like a free-floating thrombus inside the ICA, or if there is an significant intracranial atherosclerosis, all of these things actually increase the likelihood of having another stroke after TIA. Small vessel disease. Patients having small vessel TIAs, lacunar TIAs, they're very likely to have a complete stroke within the next 48 hours. There is a syndrome called as capsular warning syndrome. So this is if the person has this kind of syndrome, there's a very high likelihood of having a complete stroke of more than 40% chance of having complete stroke in the next 1 week. And how do these TIAs present? They are very stereotyped TIAs that happen, the cluster over a period of few hours to a few days. So without any cortical signs, patient will come to you with recurrent hemiparesis, without any speech problems that recover completely within a few minutes, and they cluster around for like 4 or 5 times over last 2 days. That means we can consider this as capsular warning syndrome. If you don't intervene, the patient can have a complete stroke within the next 7 days. Any atrial fibrillation or LV thrombus increases likelihood of having a stroke, or arterial dissection like an IC or vertebral artery dissection, they also increases likelihood of having a ischemic stroke after a TIA. Brain imaging. Early brain imaging, if you do an MRI scan and you find a DWI positive infarction in the MRI brain, that increases the risk of a stroke up to 7% within the next 7 days. There was another study in which the 90-day risk was increased by up to as high as 14% if in those patients who had a TIA and their brain imaging showed a DWI positive lesions. These are the few examples of DWI positive lesions in patients with TIA. You can see very small, tiny, hyperintensity in the left, in the MC distribution, and the left, see over here subcortical area, a very high intensity and DWI positive lesions. These patients present with a self-resolving right-sided weakness, but the DWI showed you that they have these tiny lesions. So these patients are actually at a high risk of having a complete stroke in the next 48 hours. So summarizing everything, how do you evaluate when you see a TIA? So you come across a patient who had a transient, stroke-like symptoms. He had it like you're in the ER. He had it in the morning. He woke up with right-sided weakness, speech difficulty, and he comes to you and says, "Doctor, I'm completely normal now." What to do? Take a history. Okay, important things in history is to know the age of the patient. Obviously, what are the vascular risk factors, the semiology, actually what happened with the patient, how the weakness started, with certain onset, gradual, and were there any history of seizure-like activity or headache, stuff like this. How much was the duration of the event, if the patient had any past, say, similar events or not. Do a complete neurological examination. So other than neurological examination, cardiovascular examination is also very important. As I told you, stroke is basically a vascular pathology. So cardiovascular examination is also very important. Examine the breathe, examine the pulses, the precordial examination. Rule out TIA mimics. We have to exclude TIA mimics based on history. Do an ECG. So what I would like to do is do an ECG as early as possible and confirm whether you are dealing with a TIA or not. So most of the times you may come across, it could be not a definite TIA but still a probable TIA. Do manage this as a definite TIA. Do urgent investigations. As I told you, whenever there is a TIA, there is a high likelihood of having a stroke. So there is a matter of urgency while evaluating TIAs. These investigations should be done preferably within the first 24 hours of presentation. Do a brain imaging and exclude a hemorrhage, and start with antithrombotics. You have to start with antithrombotics as early as possible. You have to do other imaging as well to know about the underlying etiology. Do neurovascular imaging. You can do a CT angiogram or an ultrasound carotid Doppler of the carotid arteries. Do a cardiac evaluation. You have done ECG. If there's a need, you can do an echocardiogram if there's any suspicion of LV thrombus, and also do a routine blood test like CBC and coagulation profile and other stuff. If you come across a patient, another case scenario, come across a patient who had these symptoms, right sided weakness, speech difficulty, and they have been persistent, they haven't gone away. And if the patient is within the reperfusion window, so that means it's not a TIA, okay, confirm the onset of time, the eligibility for reperfusion therapy, assess the NIHS score. If NIHS score is 6 or more, consider reperfusion therapy if the patient is eligible. So there's a different pathway for that. If the NIHS score is less than 6, treat it as a minor stroke and follow a TIE pathway. Once we have diagnosed the TIA, the next thing to do is starting with the secondary stroke prevention. So I divide secondary stroke prevention into 3 main topics. The antithrombotics, that has to be started as soon as possible, and risk factor control. Dr. Miriam talked about the risk factor control, and any interventions if required. Usually this is required in patients having an extracranial carotid artery disease, that's more than 70%. You can go for carotid endarterectomy or carotid artery stenting, and in certain patients who have atrial fibrillation and a high risk for anticoagulation, you can do a left atrial appendage closure. So these are the usual interventions we do in patients having for secondary stroke prevention. So regarding the antiplatelets, usually the antiplatelets that we use is aspirin and clopidogrel for TIA in minor stroke. What is the dose? That depends upon different practitioners. What we usually practice is we load with a high dose of aspirin and high dose of clopidogrel, 300 milligrams each, and then we, depending on the grade of the TIA, we can continue to do an antiplatelet therapy later on, usually for up to 3 weeks or 3 months. Thank you very much. Any questions? Okay, thank you.
We thank Dr. Iname Khuda for his informative talk on the early detection of stroke. We also welcome Professor Dr. Nabila Sumra, who has recently joined us in our session today. The current advancement in imaging modalities and neurovascular procedures has led us to prompt diagnosis and timely management. I would now like to invite Professor Dr. Muhammad Ali, who is working as a vascular interventional radiologist as the department head at the Zauddin Hospital, Clifton, for a session on current imaging guidelines in acute ischemic stroke in the era of mechanical thrombectomy.
Assalamu alaikum. First of all, I thanks to the organizer for inviting me for this talk, and renowned neurologists are there. So this topic is to me it's very important to talk about what should be the imaging algorithm. What should be the imaging algorithm in patients in this era of mechanical thrombectomy? Being an interventional radiologist, we are routinely doing these neurovascular interventions, and at least in my hospital, I have changed the overall imaging algorithm. And especially for those centers who are doing active neurovascular interventions, they have to follow this new imaging guidelines for the stroke patients. But for the rest, where these treatments are not available, this is still a debatable thing, and we will discuss in the coming minutes. So these are the few slides basically for the radiologists who are reporting the scans for the stroke imaging. They must be well aware of the neurovascular anatomy, their anatomical zones, as well as the various vascular territories. And one thing which is more important nowadays, being a radiologist, So being a radiologist, the clinical impact of the vascular occlusion is very important. For example, few years ago, even our radiology colleagues were not well aware of the signs and symptoms of a vascular occlusion. For example, if there is anterior cerebral artery stroke, what should be the symptom? If there is posterior circulation stroke, what should be the symptoms? So now for everyone who is reading the MRI or CT scan, he or she should be aware of these clinical impact of the knowledge. Otherwise, radiologists would be replaced by AI. So if they want to be there in the era of artificial intelligence, this clinical correlation or clinical impact should be there in every scan reporting. So the goal of imaging to establish an early diagnosis to guide the treatment, and we always, whenever you are reporting the scan, always check what is the duration of the stroke. For example, if the stroke is early hyperacute stroke from 0 to 6 hours, and that's the main time you can reperfuse the brain from either reperfusion therapy or mechanical thrombectomy, and for that you have to have a different pathway of imaging. But for the patient who have stroke, let's suppose late hyperacute or subacute or chronic stroke, you can follow the routine imaging with MRI scan. So what should be the first imaging modality? So now, before the era of mechanical thrombectomy, the mainstay of ischemic stroke was MRI with diffusion weighted imaging, and everyone was referring the MRI scan as the first imaging modality of choice to identify the acute stroke. And for hemorrhages, they usually prefer CT scan. But now the imaging guidelines have been changed, and for either ischemic or hemorrhagic stroke, the first thing should be non-contrast CT, and we have called it a new code which is called a code stroke. And this is a new protocol which we call a code stroke, and it compromises non-contrast CT scan brain immediately followed by the CT angiography, and sometimes we also perform the CT perfusion imaging. So that's the main shift from the regular imaging of the ischemic stroke. We don't get an MRI as the first choice. We always get the non-contrast CT, and if we see, so you can see here the code stroke. If the patient do the non-contrast CT head, if there is blood or no blood, in both cases you can have the CT angiography to identify. If there is bleeding, you can identify the aneurysms or vascular malformations, unless there is a typical hypertensive stroke. Or if there is ischemic signs with Alberta's score, we will see, then you can proceed for the CT angiography. So non-contrast CT scan rule out hemorrhage, detection of non-acute lesions, detecting hyperacute changes that suggest acute ischemia. This is a typical sign of intracranial hemorrhage, and then there will be a different pathway if this is a hemorrhagic stroke. And if there is no hemorrhage, then you have to look for we are very popular signs almost now. Even the radiologist, Dr. Munir, is here, we work together. So even he knows these acute signs, and they can argue with us, this patient can have acute stroke. So you can see this is an insular ribbon sign, some hypodensity in the insular cortex, and these are the signs of early stroke. Similarly, the dense MCA sign, this patient has dense MCA sign on non-contrast CT, and it was immediately followed by CT angiography, and you see the left MCA, large vessel occlusion. So we always check the Alberta's stroke score, which we call aspect score, is a 10-point score system, and you can check it's available. So you have to give numbers for various territories. I am just not going into the detail. So you can see here, this is this is basically for the MCA stroke, but now we have for the posterior circulation as well, and you have to check the hypodensity in the various regions of the brain. So if the aspect score is good and the patient has clinical symptom, for example, his NIHS score is more and there is no hemorrhage, then these patients are the best candidate for immediately going for CT angiography. And you can see for the MRI brain, it takes at least 40-45 minutes to complete the whole sequence, but for the CT and CT angiography, it can be done in 10 minutes. So it gives you a lot of time so that the patient can be shifted to the cath lab for mechanical thrombectomy, or immediately within the CT scan you can give TPA as a reperfusion therapy. So this is how it works. You have to check every slices of the brain to get the aspect score. Currently we have the posterior aspect, we call a PC aspect, posterior circulation aspect, and it has a different numbers, and lot of softwares and calculators are also available now. You can calculate these scores, either neurology or radiology residents. So you can see this case, this patient has early stroke, and you can see here there is a hypodensity here in the left anterior, right anterior basal ganglia, and the patient had an IV thrombolysis. And then what the major thing is CT angiography to get the large vessel occlusion, and that's the major advantage of getting the CT scan, because MRI usually it took a lot of time, and when you do a non-contrast MRA, it's not certain you get an large vessel occlusion. So it allows us to pinpoint the extension of the vessel occlusion, determine the location of the thrombus for the RTPA, and especially can find the tandem lesions with both intra and extracranial occlusion. So we have a new aspect score. We check the aspect score after CT angiography as well, which we call a CT angiography aspect. And I can show you in the coming example. If you see here, this patient has a plain CT first, and you can see here there is a slight hypodensity here, and we give a non-contrast CT aspect score 7. But when we get the CT angiography and we check the basic images and then identify the aspect score, the CT aspect score was 3, and we conclude that this patient is not a good candidate for mechanical thrombectomy, and the patient had developed a large malignant middle cerebral artery infarct. So with the CT source images, you again calculate the aspect score, and then you can compare it with the non-contrast CT aspect to see whether they are matching or not. So is a more CT angiography aspect is a better indicator for a large vessel occlusion. So as Dr. Inam has already mentioned that large vessel occlusion, you can see here these are the CT and MRI images. In either modality you can get this large vessel occlusion. This is right and one occlusion, and you can plan mechanical thrombectomy afterwards. So whenever you get the CT angiography, you see the early signs of ischemia, and then you get the CT angiography, and now this is the time to give the reperfusion therapy immediately, either mechanical thrombectomy or IV thrombolysis. Now we are also moving from the medial vessel occlusion, because their new devices have new small caliper intervention devices are now available, which can extract the thrombus from the medium sized vessels as well. So now we are also identifying the MEVO as well, and from A2 to A5 segment of the EC, or M2 to M4 segment of the MCA. And you can see here this is a branch occlusion which is causing infarction. You can see here this is a vessel cutoff here, and we have a small caliper aspiration catheters and low millimeter size stent retriever available nowadays. We can do mechanical thrombectomy for these MEVO as well. Very important thing, while if anyone is reading the CT angiography, always check the collaterals, because if the patient has a good collaterals, it has a very good chance of reperfusion therapy, success of the reperfusion therapy. And if there is a bad collaterals, these patients are not a good candidate. So a paucity of good collateral vessels correlate with a higher risk of treatment complication. So whenever we are planning mechanical thrombectomy, we always check the collaterals. We check the large vessel occlusion, we always check the collaterals. If there are good collaterals, this patient will get benefit from the mechanical thrombectomy. So what we call these are term good collaterals. These patients are slow progressors. Their infarct will progress very slowly, but the patient with bad collaterals, these are fast progressors with worse outcomes. So you can see here, all of these patients has occlusions within the M1 vessel. This patient has left M1 occlusion, but you can see here there is a very good collateral circulation, and this patient will have a very small infarct if untreated. Similarly, the intermediate collateral, you can see here there And but these are the poor collaterals. You can see here there is no collaterals or almost negligible collaterals, and these patients are a not good candidate of mechanical thrombectomy or any intervention, and they usually have a poor prognosis. Again, you can see here this is a CT scan MRI correlation, and you can see here this patient had a very poor collateral, and it's developed a territorial infarction of the right MCA within the 24-hour MRI, and this patient has intermediate collateral. You can see here the infarct is less on the left side, and again with the patient with good collateral, again with M1 occlusion, and you can see here there is a very small infarct in these patients. So with a good collaterals, they will have a very good impact on overall prognosis of these patients. So there are various studies which shows this overall infarct progression is good, is very good in patients with good collaterals. With definitely with recanalization, there is less infarct progression, and with non-recanalization, even with non-recanalization, there is a better overall outcomes in these patients. So we have various collateral. I am not going into the detail. This is basically for radiology. You can see here there are a lot of collateral scoring systems, and you have to identify overall what's the score of the collateral vessels. Then there is the role of CT perfusion imaging. So what's the basic utility of CT perfusion? Sometimes the patient comes us for mechanical thrombectomy in a borderline zone, or for example the patient came for a wake up stroke. We are not entirely sure what's the actual window of or duration of the symptoms, and indeed in these cases if you have a borderline aspect score like 6 or 7 with large vessel occlusion, it's always preferable to get the CT perfusion, and you can get the CT perfusion immediately on that same CT scan. So some majority of the people give another bolus of contrast and get the CT perfusion. It takes another 5 to 10 minutes. So whole imaging of the cord CT can be completed in almost 15 to 20 minutes, and with the CT perfusion you can check whether the brain is salvageable or not, whether the stroke is reversible or not. Whenever it is reversible, so we have to see whether there is a core infarct or a penumbra infarct, and there are few things like mean transit time, cerebral blood flow, and cerebral blood volumes. So these are some technical, not every CT scan can do these. So there is at least 64 slices or above with processing software, and you give a good cannula for a good infusion of the contrast. And these are the few parameters things. So what is the penumbra? Penumbra is the area which can be reversible. So whenever you see a good penumbra during CT perfusion, this case is a good candidate for mechanical thrombectomy or referred perfusion therapy. And what is the basic sign? The transit time of the blood is definitely will be increased, but the overall blood volume will not get decreased. So that's a major thing. There is a mismatch between the MTT and the cerebral blood volume. I will show you in the coming images, and you can see here this is the penumbra and this is the core infarct. So whenever the stroke develops, you can see here initially there is auto regulation of the blood, and there is increased blood volume and increased mean transit time. The cerebral blood flow usually is preserved, but whenever there is penumbra, you can see here the transit time starts to get increased, and there is less or almost similar cerebral blood volume from the baseline. But in the core infarct, you can see the cerebral blood volume is markedly reduced as well as cerebral blood flow. You can see here, see this blue cerebral blood volume. It's normal in penumbra and it's very bad in core infarct. So this is normal perfusion of vein, and this is a penumbra. You can see here is a small defect here, but you can see the cerebral blood volume is normal, and this is the core infarct. You can see here this is markedly reduced. It's colored. There are a lot of color coding to identify it very easily, and you can see here these infarcts are core infarcts with blue color and reduced cerebral blood flow and the cerebral blood volume. Another large core infarct, you can see here the markedly reduced cerebral blood volume and cerebral blood flow. These are irreversible, and there is no need of doing any intervention. You can cause harm to the patient, because after every mechanical thrombectomy there is risk of reperfusion hemorrhage. So better not to treat these patients, just give them on conservative treatment. Another patient with large core infarct, this patient you can see here is a ischemic penumbra. CT is normal almost. This is the posterior branch of the left MCA. You can see here there is some reduced cerebral blood flow, but the cerebral blood volume is absolutely normal, increased mean transit time, and this is a typical ischemic penumbra, and these patients get benefit from the mechanical thrombectomy. Another thing very important, one of my case, you can see here, always check carotids in CT angiography. Like Dr. Anam Khuda mentioned, is small infarct, and there is a very bad calcified carotid disease with incomplete cycle of Willis, and these sort of patients will have a very high chance of severe right MC infarct in the future. So we put the carotid stent with a very tight stenosis, and we did the angioplasty of this case, and you can see here there is increased blood flow in this case. So whenever we are doing stroke interventions, we always check the carotid. Sometimes we put stents in the carotid as well. So CT in a nutshell, you have to start with the CT plain imaging, and when there is aspect score is recommends to get the CT angiography, get the CT angiography. Whenever there is confusion or a borderline infarct, get the CT perfusion, and you can decide whether, you can see here, this red is the core and yellow is the penumbra. Briefly discuss the MRI, definitely more time consuming, not readily available. For example, you know, there are many institutes which have scanners like less than 0.1 Tesla, which don't have. They usually say we have diffusion weighted images, but these are not actually diffusion weighted. These are T2 shine through images. They don't have a actual diffusion ADC map. So they will give you a false reading every time you are asking for DWI stroke protocol in these open low field magnets. So, but the CT is readily available everywhere. So if the perfusion is not available, still you can get the CT angiography very fast, and that's why the main lesson for in this new era of mechanical thrombectomy, you can proceed for CT angiography first. That's the main thing. So MRI, you can see, I will just show you, there is a chance you can get a negative DWI imaging, and believe me, I have done, in my personal experience, I have one young guy during the COVID era who come with the symptoms of posterior circulation stroke. You see here, this is the posterior fourth infarct. These are the most common things, patients which do not have a signal abnormality on DWI imaging. This young patient came within the window, MRI was done, MRI was normal, the patient deteriorated. After 6 hours, MRI repeated, and MRI shows a large brainstem infarct. We immediately performed the mechanical thrombectomy, removed the thrombus from the basilar artery, but the patient did not survive. So it's very unfortunate for us, but it's a lesson for us. For these large vessel occlusion, CT with CT angiography is superior than the MRI. This just like how you can see the acute infarct. Everyone knows this, and we always compare the DWI with ADC mapping, and this is only available in superconductive 1.5 Tesla or above MRI. One thing is important, if you have done, in any case, if you have done the MRI imaging, then still you can check whether the brain is salvageable or not, and you can see here, this is a DWI image. There is a large area of perfusion defect, but this is a flare. You can see there is very minimal changes. So this means that there is a diffusion flare mismatch, and this is a penumbra. So if the infarct is developed in both DWI and flare, then it's a core infarct and it's not reversible. So if you have an MRI and if you have done the MRI, still you can try to identify whether this is salvageable or not salvageable by looking at the diffusion as well as flare images. Again, you can see here, this is there is a small defect within the flare, but diffusion shows a large defect. So still you can see this is a salvageable brain. So MRI can be performed in patients who you could not give the CT angiography, but it has limitations definitely. And similarly, you can get the MRI perfusion as well. I am not going into the detail. So the latest trend and latest research is, when initially the MRI was the king, but the CT angiography became the king. Now MRI is trying again, and the people are doing researches, and they are saying if you do the MRI with MRA, and now they have made a new code which is under investigation in many countries, which is code MRI. You get the MRI diffusion weighted images, get the MRA contrast enhanced MRA, and get the MR perfusion if required. So technically you can get this if it is available, but definitely a lot more time consuming. But what they are advocating that with MRI planning, there is more better prognosis after stroke intervention. So let's see what will be the decision in the future and who will take the lead. So DSA we only performed whenever we plan to shift the patient for mechanical thrombectomy. Sometimes there are many articles and a lot of people think whenever the patient has a typical acute ischemic stroke, and you get the CT plane and again shift the patient to the angiography and get the angiography just to take more time, especially those patients who are in the border zone. For example, the patient is just 5 to 6 hours already have passed, and you want every minute in these patients is very important, so you can directly shift the patient for DSA after getting CT plane. Secondly, now currently our new DSA machines have CT incorporated, what we call as a cone beam CT or a dyna CT. So what one option we have, we can shift patient directly to the angiography table, get the CT cone beam or dyna CT, see whether there is hemorrhage or not, get the aspect score. Although its quality is a bit inferior to the main CT, but you can get the CT and get the DSA as well to just get the fast result. So this is the DSA showing one of the thrombectomy case. So mechanical thrombectomy usually we do in the less than 6 hours. Pre-scores definitely a modified ranking score is deranged with an aspect score more than 6, NIHS more than 6, age usually more than 18. Although we are not getting, if a young stroke is there, we can also try to get it done, and we try to get the growing puncture within 6 hours of stroke symptoms. The few other techniques, this is a Sophia catheter. It's a very soft catheter. We just go inside and suck the thrombus out, and then if it doesn't work, then we put a stent, and with the help of stent, you get this clot out. You can see here. So this is a stent retrieval technique, and this is the adapt technique. So these are two major techniques. Sometimes to combine these techniques, which we call a solumbra. So this is a simple aspiration or adapt technique. This is a stent retrieval technique, and this is a solumbra technique. So our first case we performed in 30th October, just the next day of the World Stroke Day, and this young patient has developed presented with MCU occlusion. We immediately get the DSA, and you can see here this is solumbra. This is the adapt technique. We aspirate the clot, and the patient is fine, and still in 4 years follow-up, the patient is fine. And you know immediately when the patient was aphasic with has a weakness in the left half of the body, immediately when I aspirated the clot, the patient started talking and get better, and he was even insisting to get discharged on the same night, but our neurology team persuaded him just to be there at least for 1 day. So this is how it works. Just a brief introduction of our neurointervention facility at Dr. Ziauddin Hospital. We are mainly doing brain aneurysms and brain flow diverter carotid stenting. We have done so far 11 stroke cases in 5 days, thanks to the free of cost services to NICVD. Now the major patients are doing here, which is good. At least the patient has a facility, and we are treating other cases as well. And one more thing for the non-affording patient, we have international collaboration. This is Dr. Changiz Jadoon. He was in the Aachen, and then he routinely came to us. Dr. Fan Lutfi is also a member of our team, and we are doing these cases at Ziauddin Hospital. This is Dr. Fazal Zaidi, Dr. Isham Salahuddin. They both are neurointerventionists in USA. And we did Dr. Sam Zaidat, who is the president of the Society of Vascular Intervention Neurology in USA. And they came to us. They take a lot of free inventory with them, so that we can do these interventions. For example, at least I have 2 to 3 free of cost sets of stroke intervention available at my hospital for any needy patient who cannot afford the payment of, because they are very expensive, otherwise they are very expensive treatment. Similarly, flow diverters are very expensive, around 30 lakhs for one flow diverter for a brain aneurysm, but we are doing these procedures with very minimal hospital cost, like 2 to 3 lakhs, just the admission cost, ICU cost. So with this, with Dr. Brian Djokovic, he is also from and Dr. Fazal Zaidi, so they are routinely come to our hospital, and Dr. Fadil Siddiqui is also neurointerventionist in the University of Michigan, and Dr. Akhil Pavani is a vascular neurosurgeon in Florida. So they usually came to us. We have international collaboration for the poor patients. This is a summary of acute stroke. Always start with CT angiography, and if required perfusion imaging, treat with the DSA, and if you require get the MRI, there is a definite role. So take home message is the element of mechanical thrombectomy, core CT comprising plain CT, CT angio and perfusion is the mainstay of acute stroke imaging. Definitely MRI has a more role in the future to come. More needs of more stroke center with mechanical thrombectomy services and collective efforts of radiology, neurology and cardiology for prevention of stroke and their morbidity. Thank you.
We thank Professor Dr. Mohammad Ali for updating us about the recent advances in neurological interventions. Rehabilitation in stroke helps to regain independence and quality of life and has a strong impact on patients physically, socially and emotionally. For discussing the importance of rehabilitation in stroke, I would now like to invite Professor Dr. Nabila Sumro, the Executive Director of the Sindh Institute of Physical Medicine and Rehabilitation.
Bismillahirrahmanirrahim. Assalamu alaikum and thank you Dr. Khalid Sher, Professor Khalid Sher, Dr. Malik, and salams to Dr. Nadir Ali Sayyed and Dr. Shahid Mustafa. And I'm glad to see young neurologists here. That shows that they feel that importance of neurorehabilitation, how neurology and rehab goes hand in hand. So I'll just quickly take you through the, am I audible? Okay. So I'll quickly take you through the, so this is the first multidisciplinary civilian and public sector institute which caters to musculoskeletal, pediatric, amputee, neuro and cardiac rehab. So today I'll only take you through the journey that what do we do with stroke patients when they walk in. Just few pictures from our stroke rehab floor. All evidence based, you can go. So stroke rehab or neuro rehab revolves around theories of neuroplasticity. Any idea what is neuroplasticity? That whatever peripheral input we gave, the brain reorganizes. So these are 7 pillars which revolve around neuroplasticity, and they support recovery after stroke. So I won't go into the detail, but my lecture would be here. You can anytime take it and the explanation is there. So stroke rehab is not a one-man show. You need a full team around patient. Of course, rehab physician, or you can call a rehab physician a physiatrist. It might be a new word because we are often quoted as physiotherapists. So physiotherapists, occupational therapists, prosthetics and orthotists, neuropsychologists, they all work with us as a team, as nurses work with you. So they are very important members of our team, but stroke rehab is a teamwork. Okay, so what's the criteria? When do you shift patient or when do you refer patient to us? So these are criteria that, of course, a stable neurological status, but at least patient should reach us in first 3 months. That's a golden period for rehabilitating the patient. So I've penned down few things that when can a stroke patient physically tolerate the journey of neuro rehab. So any of these red flags, then you need to wait before you send them to us. FIM scale, this is an international scale which just shuttles between rehab physicians. From this scale, we know how independent the patient is. So when you send us, you must have a fair idea that what are the patterns of recovery. So you must know that if this is a pattern of recovery, he's a good candidate for neurorehabilitation. Often हमें ये realize होता है कि when the stroke patient is admitted, you are the first line. What happens अगर आप stroke, I don't know whether you've gone through the book, that stroke, जब 100 stroke patient से पूछा गया तो वो जो लेफ़्ट थे, जो लेफ़्ट राइट ब्रेन इंजर्ड थे और लेफ़्ट हेमीप्लीजिक थे, उन्होंने कहा कि दे वर यूजिंग वर्बल लैंग्वेज. ठीक है, और उनकी आपको ये बहुत अच्छी तरह से समझ लेना चाहिए कि चाहे वो हमारे पास हो या आपके पास हो, लुक एट ऑफ द लीजन एंड देन अकॉर्डिंगली एड्रेस देम वर्बली और बाय बॉडी लैंग्वेज. और आपको लेफ्ट हेमीप्लीजिक में विजुअल स्पेशल डेफिसिट्स, निगलेक्ट, ये सब चीज़ें जहन में रखनी चाहिए. So first week, what should be the position? The shaded part is hemiplegic or hemiparesis portion. These positions are just there to avoid flexor synergy in upper limb and extensor synergy in lower limb. जब हमारे पास पेशेंट पहुंचता है, अवल तो बहुत मुश्किल है कि विदिन 3 months पहुंच जाए, लेकिन जब वो पहुंचता है तो फ्लेक्सर और एक्सटेंसर साइनर्जीज डेवलप हो चुकी होती हैं, एंड विच आर वेरी डिफ़िकल्ट टू ब्रेक आफ्टर 3 months, बट दे आर वेरी ईजी टू ब्रेक विदिन 3 months. बहुत सारे स्ट्रोक पेशेंट्स को मैंने एक्यूट में देखा है कि उनको स्टॉकिंग्स पहना दी जाती हैं. स्टॉकिंग्स आर नॉट इंडिकेटेड. इफ़ यू वांट टू गिव देम ट्यूबी ग्रिप, और यू कैन जस्ट प्रोवाइड दिस मशीन फॉर देम, CPM और वीनस कंप्रेशन पम्प्स. और आप उनको अगर सिंपल पैसिवली कोई केयरर है या आपके पास नर्स, रिहैब नर्स है, तो वो एवरी 2 hourly क्लॉकवाइज या एंटी क्लॉकवाइज उनके एंकल को हिला दे. दैट कॉजेज अ पैसिव पंपिंग ऑफ काफ मसल्स. स्टॉकिंग्स आर जस्ट एक्सटेंडेड सॉक्स जो इमोबिलिटी को. सिटिंग पोजिशन, कुछ सिटिंग पोजीशंस आर कॉन्ट्राइंडिकेटेड और अक्सर पेशेंट इसी हालत में होते हैं. ये सिटिंग पोजीशन इनकी कोर स्टेबिलिटी को बहुत सिवियरली अफेक्ट करता है, फिर बाद में इनका सिटिंग बैलेंस अटेन करना बहुत मुश्किल होता है. सो दीज आर, आई एम जस्ट टॉकिंग अबाउट अक्यूट स्ट्रोक मैनेजमेंट इन द, बिकॉज जब आपके पास हो तो आपको क्या करना चाहिए. दिस काइंड ऑफ सीटिंग is easily available and evidence based है कि this should be given in order to avoid pressure sores till they become mobile and mobility. Position किस तरह change करनी चाहिए every 2 hours. Core stability is very important while the patient is lying on the bed. ये simple exercises है, if they are encouraged during the first week, they develop good core stability for us, ताकि हम बाद में उन स्ट्रोक पेशेंट को मोबाइल कर सकें. चेस्ट थेरेपी अगेन इज़ वेरी इम्पॉर्टेंट. इट गोज़ हैंड इन हैंड विथ योर पोजिशनिंग. शोल्डर पेन बहुत ऑफन हम देखते हैं. वजह क्या होती है कि जो शोल्डर डिप्रेसर्स हैं ना, वो पहले स्पेस्टिसिटी डेवलप कर लेते हैं बिफोर एलिवेटर्स, सो दे पुल द ग्लूमरल हेड डाउन. सो इट्स वेरी इंपॉर्टेंट कि इनिशियल डेज में अगर आप शोल्डर का ख्याल रखें कि यू हैव टू रैप योर हैंड अराउंड द चेस्ट टू डू द ट्रांसफर्स, लेकिन अक्सर हम लोग शोल्डर और एक्सिला से पुल और पुश कर रहे होते हैं. सो सिंपल हमारे यहाँ अक्सर ये वाली स्लिंग दे दी जाती है विच एग्रीवेट्स फ्लेक्सस एनर्जी. सो यू कैन यूज़ वेरी सिंपल homemade assisted devices just to keep the humeral head up and just don't pull the patient from axilla. Shoulder pain बहुत important है, so you have to address right in the beginning. बाद में we do treat them, but it's a bit difficult. I have to scroll through quickly slides because I have to finish within my time limit. Transfer techniques. आपको हमेशा उनकी पैंट्स या पजामास के थ्रू ट्रांसफ़र करना चाहिए, not through axilla and not through no pressure on any pelvic bone. Transfer boards are a very good option to train them during the first week. Very simple techniques and then they are independent in transfers. No, ये वीडियो चल पड़ी? ओके चल पड़ी, ओके. सो मोबिलिटी असेसमेंट शुरू में बहुत ज़रूरी है क्योंकि एक्सटेंसिव एनर्जी होती है, दे वॉक विद एन इक्वाइनोवेरस पैटर्न. सो ये बहुत छोटी सी चीज़ें कि हाउ डू यू break those extensive energies. How do you, during the first week, create a balance from static standing to anti-gravity movements and then to simple balance and coordination exercises. So you have to assess also and also move forward. So core stability, balance exercises, contralateral crossed exercises, they are very important to break this energy and then develop the balance so that the core stability and balance is addressed right at the first week before they come to us. So these are very simple measures so that when we get the patient, he can just go walking within few weeks instead of bed bound. So this was just last month video. Next, hand rehab is very important. बहुत ज़रूरी है कि ग्रॉस और फाइन हैंड रिहैब पे वर्क किया जाए. यू हैव टू असेस कि क्या है, मतलब व्हाट इज़ ग्रॉस मिसिंग है, फाइन हैंड रिहैब मिसिंग है, एंड देन यू टेक देम थ्रू द होल जर्नी ऑफ हैंड रिहैब. पहले आप ग्रॉस डेवलप करेंगे. CIMT is nowadays usually used that you encourage the affected hand to be used in different activities depending upon कि उसका status क्या है. So CIMT is nowadays very much in fashion. So then you start working on their grasping, drawing shapes. So this is a whole journey they undergo on a hand rehab floor. Then you give them gravity assisted exercises, then anti-gravity, and then so on. Then they come to the therabands, therapies. Therapies are for fine hand movements because fine hand movements you cannot develop without therapy. So they come in different and we progress them accordingly. So then you train them for their fine hand movements. इनका सबसे ज़्यादा कंसर्न होता है कि हम कब चेक बुक लिख सकते हैं या कब कुछ वट एवर द जॉब इज़ वेर. सो दिस इज़ जस्ट थोड़ा सा एक जस्ट अ स्मॉल वीडियो टू शो यू के वी स्टार्ट फ्रॉम शोल्डर, देन यू कम टू द फोर आर्म एंड देन यू कम टू द हैंड टू डेवलप देयर. सो these are just small glimpses from our hand rehab floor where they undergo gross and fine hand movements. Bladder and bowel management. हमें जब भी पेशेंट्स मिलते हैं कैथेटर के साथ और बाउल पे कोई काउंसलिंग नहीं हुई होती है, सो व्हाट इज़ लेटेस्ट एविडेंस, कैथेटर कब रिमूव होना चाहिए? विदिन 48 आवर्स. And then you train the patients if they are cognitively sound, stable neurologically they are stable, you can quickly train them for timed voiding. So similar recommendation for bowels, you must know their bowel habits and then accordingly train them. So our bowel and bladder clinics just train them to become independent in their bowel and bladder regime. Facial paralysis, again, our colleagues spoke about it. So we begin with small exercises once patient is with you all, and then gradually we take them over. language and swallowing. What are the initial steps? You must know how to, what are the steps कि आप चेक कर सके इनिशियली कि swallowing deficit है या नहीं है. बहुत सिंपल है कि आप 5 cc क्रश्ड जो हम गोला गंडा खाते हैं, कितनी क्रश्ड आइस होती है, वो आप पेशेंट को दें. वो ग्रेजुअली ड्रॉप बाय ड्रॉप डिज़ोल्व होती है एंड यू नो कि कोई उसको swallowing इशू है तो आपको वहीं पता चल जाएगा. एंड देन इफ देयर इज़, you just send them or refer them over. We have a floor for language, swallowing. So these are just few tips. You just ice them, flex their neck to 30 degree. They must hold their breath. Ice ka crush spoon दें and then see how the patient behaves. Bedside test, कि you have to refer them to us for speech therapy. So does he understand? Can he talk? Can he repeat? Can he read? Or can he write? अगर इनमें से कोई एक भी चीज़ नहीं कर सकता तो communication board, this is very important. ये board हर stroke patient के next door उसके draw में होना चाहिए along with other things like उनके specs हैं, उनकी daily use की जो चीज़ें हैं. लेकिन if you read जो 100 पेशेंट्स की पोस्ट स्ट्रोक पेशेंट्स जो उनकी शिकायत थी कि व्हेन वी कुडंट एक्सप्रेस, तो अगर हमारे पास ये बोर्ड होता कि अगर वो लुकिंग एट द लैटरलिटी ऑफ द लीजन, अगर वो आपको अपने जेस्चर से समझाना चाह रहे हैं तो यू नो दिस इज़ द बेस्ट ऑप्शन फॉर यू टू कम्युनिकेट विद देम. जब ये सब ख़त्म हो जाता है तो देन वी train them for their bathing, grooming, toileting, dressing, eating. So that happens in our activities of daily living floor. और वहाँ हम patient को train करते हैं कि वो gradually वो किस तरह. These are assistive devices which our fourth year occupational therapy students along with our faculty they prepare. So these are bathing, dressing, grooming, eating devices, and we give them as a project so that the patient can get them for free. So this is our lab where they are made and they are provided to patients. So not only to stroke but to like weighted utensils or weighted cutlery is given to Parkinson's patient so that can dampen their tremors. So this floor makes all assistive devices. This is our occupational therapy floor. So this is how they modify cutlery and dressing aids, eating aids. So they are trained how to button their shirts, how to dress and undress. Neurocognitive evaluation, very important. So you have to have neurocognitive evaluation to see that are they suffering from any of cognitive deficits which make their life not functional later. So basic test आप यहाँ करवा सकते हैं. Give them a puzzle कि वो human body को in order रख सकते हैं. Right left discrimination है. Can they pick up few things from a basket? Put few things in a basket. See if they can pick up one which you just ask them to pick up. Cancellation of the words. Okay, write down A on right and left and you ask them to cancel. So if there's right left discrimination, they'll be cancelling all words on the right and nothing on the left. And then figure. So for spatial or unilateral neglect, just ask them to make simple drawing and you'll at once pick them up. And then rest of the work is ours, that how to develop their cognitive functions. So cognitive therapy is very important for stroke patient. Post-stroke depression, of course, this is one thing when they come to us, you start them with antidepressants and when they arrive but then we start our psychotherapy sessions also with them and with the family. Family is again very important. We tend to ignore the carer. आपको पता चल जाएगा, रिहैब में पता चल जाता है कि कैरर जो है वो असल स्ट्रोक पेशेंट से ज़्यादा डिप्रेस्ड है क्योंकि सारा लोड उस पर आ जाता है. सो व्हाट्स द रोल ऑफ ऑर्थोसिस? AFO हम बहुत इजीली लिख लेते हैं. वी हैव टू नो कि व्हेन टू गिव एंड व्हेन नॉट टू गिव. सो दिस इज़ आवर ऑर्थोटिक एंड प्रोस्थेटिक फ्लोर where we make all kind of orthosis and of course AFOs for stroke patients also. So there's a strong evidence level 1 कि AFO should be recommended अगर equinovarus spasticity है. ठीक है, so we do give them. और ज़रूरी नहीं है कि आप बहुत महंगे और बहुत एक्सपेंसिव लें. Even a simple sponge can do the work. So of course आपकी जो असिस्टिव डिवाइसेस हैं, चाहे व्हील चेयर्स हैं, असिस्टिव डिवाइसेस हैं और कम्युनिकेशन एड्स हैं, दे आर वेरी इम्पॉर्टेंट. फॉल प्रिवेंशन इज़ वेरी इम्पॉर्टेंट. तो आप हिप प्रोटेक्टर्स दे सकते हैं, जो भी फॉल प्रिवेंशन टेक्निक्स हैं कि घर में रग्स किस तरह हो, लाइटेड कैसे हो, एंड आई एम श्योर यू ऑल मस्ट बी अवेयर ऑफ इट. It's a vascular event, so you have to take your stroke patient to your cardiopulmonary rehab floor ताकि आप उनकी risk factors पे काम कर सकें. Being a part of international cardiopulmonary rehab, आपको पता है कि अब जो 5 major risk factors हैं वो हैं आपका physical inactivity, if you are walking less than 10,000 steps per day, the kind of nutrition you are eating, अगर Mediterranean fruit, vegetables 3/4 plate में नहीं है. Third is your anxiety, depression, sleep hours and your waist size. They say if you control, and you of course smoking या गुटखा जो भी, they say if you control these, don't worry about your diabetes, your hyperlipidemia and your blood pressure. So I'm not going to talk about cardiopulmonary rehab now, but in the end they have to go through cardiopulmonary rehab. So this is a take home message. लेकिन अब पाकिस्तान में टैक्स इतना बढ़ गया है कि पता नहीं ये मुझे स्लाइड डिलीट करनी चाहिए फ्यूचर में. So thank you so much for your patience.
We thank Professor Dr. Nabila Sumro for highlighting the importance of physical rehabilitation in stroke. We hope that you all learned a lot during this informative seminar today. For any further questions and answers session, I would like to invite all our honorable panelists to answer any query by the audience related to stroke. We already have our chairperson, Dr. Nadir Ali Sayed, co-chairperson, Dr. Mohammad Shahid Mustafa, and our head of department, Professor Dr. Khalid Shir on stage. We would also like our other guest speakers, Professor Dr. Abdul Malik, Dr. Mariam Javed, Dr. Naame Khuda, Dr. Mohammad Ali, Professor Dr. Nabila Sumro, Professor to join us for this Q&A session. Questions by the audience?
Practice, so we are very financially not constrained. तो उसमें सर्टिफिकेशन प्रोफेशन साथ में उनका CT एक रेफर आउट कर सकते हैं और MRI पूरा नहीं कर सकते अगर वो विंडो क्रिएट करना है तो
ये तो हो गया इवन मैं तो बताता हूँ कि फ्री ऑफ कॉस्ट भी कर सकते हैं। चलो हॉस्पिटल चार्ज भी उन्होंने कहा मैं वे ऑफ कर सकता हूँ। मगर कई दफ़ा ऐसा होता है उस पेशेंट को, मुझे याद है कि एक रिक्शे वाला था, तो अपनी वाइफ को लेकर आया कोई इंजेक्शन लगवाने कहीं पर, तो वो फ़ौरन ही हमारे पास आ गया, तो हमने उसको सीटी कर लिया। उसके बाद उसने कहा कि मैं सीटी करा सकता हूँ और मेरे और मैं फिर उसको मैंने कंट्रास्ट कहीं से अरेंज करके सीटी एंजियोग्राफी करा। एंड देन वी ऑफर दैट कि हम इसको मैकेनिकल थ्रोम्बेक्टमी कर देते हैं। और एक इत्तफाकन बात ये थी कि NICVD में जहाँ पे स्ट्रोक होना था वहाँ डॉक्टर खान दूसरी करते हैं, तो वो भी किसी केस के सिलसिले में आए हुए थे, तो वो उन्होंने उसको कहा कि मैं भी करता हूँ वहाँ, और वहाँ पे भी सामान नहीं तुम्हारे यहाँ फ्री में इन लोग ऑफर कर रहे हैं। और उसके दिमाग में जो ऐसा छाया हुआ था तो मैं जल्दी आ जाऊँगा, पता नहीं कितने पैसे लेंगे, एक फ्री करके किसी जाल में मुझे फंसा रहे हैं। तो वो बहरहाल अपनी बाइक को ले लिया वहाँ से, और उसको कोई फ़ोन कर रहा था मुझ सके, और डॉक्टर खान ने भी अफसोस किया, मैंने भी अफसोस किया, डॉक्टर हाथ ने दिया दिया कि वो बेचारा बहरहाल वहाँ आउट ऑफ विंडो जाके पहुँचा। वहाँ पे सब सामान कभी अवेलेबल ऐसा हो गया था, टाइम 24 हो गया टाइम कि आई थिंक 2022 की बात थी, तो वो अवेलेबल नहीं था और नहीं मिल सकता। मगर ये तो मैंने आपको एक मिसाल दी, मगर ऐसे भी पेशेंट्स हैं कि जिनको हमने ऑफ़र की और वो डॉक्टर से हाई प्रोफाइल थे, और आपको पता है जितने हाई प्रोफाइल हैं वो तो JPMC या NICVD जाना पसंद कोई ना कोई लिंक निकाल लेते हैं। तो एक पेशेंट थी मुझे याद है, उसके दोनों बेटे डॉक्टर थे और किसी सीनियर पोस्ट पे थे, तो इमीडिएटली उन्होंने शिफ्ट किया NICVD और उन्होंने वहाँ पर स्टोर इंटरनेशनल कर ली। दैट्स हैपनिंग एक्चुअली। तो आप लोगों को आसानी है कि आपके तो बहुत करीब है NICVD, कोई दूर है ही नहीं। तो अगर JPMC के अंदर आप लोग एक कोड CT करते हैं कि CT विद CT एंजियो, तो आपको तो मेरे 5 मिनट लगने चाहिए जितनी देर में पेशेंट ट्रांसफर हो जाए।
So I would like to add something. So I think that the important point here is regarding a referral of acute stroke patient, not acute stroke patient. And in that case, the traditional way of referring in our setup is just to ask the patient sign down of form and go wherever you want to, or go to trauma center, wherever. In hyperacute stroke patients, I think the referral should be informed referral. And we at the Pakistan Society are working with the Lebanon Medical Ambulance Services for a proper stroke referral, for a proper stroke transfer. So we are in a kind of a communication at the moment and formal discussion, looking towards that possibility of having a kind of network between thrombectomy centers and stroke centers, how to properly refer them to save time. The main issue is of that of time. So to save time should be informed referral. The patient should be reaching at the thrombectomy center and directly, preferably directly to the NGSU, because the scans have already been done. We don't have to waste time in the ER, get the scans done again. All the information have been transferred, and you can bring the patient directly to the NGSU. And that's what we are thinking of having it happen. At least it hasn't happened right now, but inshallah that's the plan in the future.
एक चीज़ मैं थोड़ा सा ऐड करूँ, मैं जब आप हमसे 2011 में मेरी फेलोशिप खत्म हो रही थी और मैं बड़ी जगहों पर ज़्यादा कर रही थी, अभी भी था, तो उसका डॉक्टर अजीम जो मेरे प्रोफेसर थे उन्होंने मुझे कहा कि अब 13 साल हो गए बाद, उन्होंने मुझे कहा कि यार JPMC में एक कैथलैब लगी है, उसको भी किसी ने लगाया था तो चली नहीं है। मैं कहता मैं तो चाहूँगा कि वहाँ पे भी ये इंटरवेंशन स्टार्ट हो जाए, तो हल्दों के कुछ वो मुझे पता नहीं चला कि उसकी फंक्शनैलिटी है या तो बहुत टाइम हो गया। तो फिर मैं डॉक्टर तारिक महमूद से कई दफ़ा कहा, डॉक्टर खालिद शेर भी हैं, बाकी लोग भी मौजूद हैं, कि आई थिंक JPMC जितना बड़ा इदारा है वहाँ पर ही अगर सर्विसेज स्टार्ट हो जाए तो हम हर किस्म की कोलैबोरेशन कर सकते हैं। मैंने इंडस में कई पेशेंट फ्री ऑफ कॉस्ट जाती थी और उनको भी मैंने कहा कि आप स्टार्ट करें, स्टिल वी नीड अ लॉट ऑफ लो कॉस्ट सोल्यूशंस, जैसे डॉ यूनिवर्सिटी में स्टार्ट हो गए। सो आई थिंक दैट्स वन थिंग इट कैन बी डन।
I would just like to make a comment. I think we are in the era of mechanical thrombectomy and IV TPA. And that's what we hear about when we hear about stroke management. And it is really magical. एक चीज़ होती है numbers needed to treat. आप कितने मरीज़ों को एस्पिरिन देंगे एक साल तो एक स्ट्रोक रुकेगा. The number is 224 मरीज़ों को एस्पिरिन देंगे तो एक स्ट्रोक रुकता है. अब नंबर फिर TPA, आप कितने मरीज़ों को TPA देंगे तो एक मरीज़ का बहुत अच्छा आउटकम आएगा. The number is 10. within the first 3 hours and 23 hours to 4.5 hours. तो यानी कि 10-20 लोगों को देना होता है. मैकेनिकल थ्रोम्बेक्टोमी के अंदर अभी एक अर्नीज मेटा एनालिसिस हुई है, 5 ये सारे मिस्टर क्लीन, स्विफ्ट, इंटरैक्ट आइए, देखा यू ओनली नीड टू ट्रीट 2.4 पेशेंट्स टू हैव वन गुड आउटकम. Now this is very attractive and glamorous, but there is another side to it. UK के अंदर only 3% of strokes get mechanical thrombectomy. पाकिस्तान में हेल्थ केयर पे $3 बिलियन खर्चते हैं, अमेरिका में $4,500 बिलियन खर्चते हैं. कोई पैसे की कमी नहीं है. वहाँ पे सिर्फ 5 or 6% of patients get mechanical thrombectomy. Less than 10% get TPA. तो जब हम स्ट्रोक सुनते हैं, these are miracles that need to be propagated and put forward. मगर जो गेम है ना, वो सारा ब्लड प्रेशर और मॉडिफाइबल रिस्क फैक्टर्स का है. जब हम बात करें 5% of strokes, 10% of strokes, about 50 to 60% of stroke is attributable to hypertension. अभी हमने डॉक्टर मारिया के थ्रू सुना था कि 10 मिलीमीटर मर्करी कम करने से 33% बेनिफिट होता है. कहीं कहीं 25 भी होता है, कहीं कहीं 40% भी होता है. तो वहाँ पे हम बात करें 3% स्ट्रोक रोकना, यहाँ बात करें 30-40% स्ट्रोक रोकना. Because all of us, most of us are physicians here, one thing you can take from this meeting is that if you just control the blood pressure, you have an impact of maybe 30% of patients, just 10. और आप ज़्यादा करो तो और ज़्यादा फ़ायदा होगा. So the reason I wanted to make the comment is कि while TPA and mechanical thrombectomy are the way forward, but they are a very small number of stroke patients. Majority still is hypertension. सबसे ज़्यादा hypertension, फिर आता है diabetes, smoking, cholesterol, obstructive sleep apnea, lifestyle, exercise. I just thought I would.
I think सबसे पहले तो it's a wonderful CME. All credit goes to Dr. Malik, who is the president of the Stroke Society. World Stroke Day पे, I think he has taken the advocacy in neurology and stroke to another level. So I think we must appreciate his efforts in the advocacy. And also thank you, Dr. Khalid Sheikh, for hosting this event. His team. I have come to this building after a long time. मैं तो कहीं और तलाश कर रहा था, मैंने कहा था ये कौन सी बिल्डिंग है. So it's an amazing transformation, and I think best of luck to your future. And also great talks by all the speakers. I think I've learned quite a few things. A lot of hard work goes to it. Amazing talks. And I think adding to what Nadir has said and picking a line from what Dr. Mariam has said, I think हम सारी पेशेंट्स की बात करते हैं, लेकिन आई थिंक ये जो हम हेल्थ केयर प्रोवाइडर्स हैं, आई थिंक हम बड़ी प्रेशियस कमोडिटी हैं इस सोसाइटी की. और टेकिंग केयर ऑफ आवर हेल्थ इज़ वेरी इंपॉर्टेंट. एंड पेशेंट्स एक्चुअली टेक अस एज रोल मॉडल्स कि हम क्या कर रहे हैं, हमारी हैबिट्स कैसी हैं, हमारी अपनी हेल्थ कैसी है. और डॉक्टर नादिर ने जो बात की, अगर हम इस सारे टॉक्स को घुमाएँ, अल्टीमेटली हर चीज़ बॉयल डाउन होती है आपकी रिस्क फैक्टर्स पे, और वो भी सारी बॉयल डाउन होती है दो ही चीज़ों के ऊपर, हमारी फ़िज़िकल एक्टिविटी एंड हमारी डाइट. और वो भी अल्टीमेटली बॉयल डाउन हो जाएगी हमारी हैबिट्स के ऊपर. हैबिट्स है ना, वो लाइफ लॉन्ग बनती हैं. आप लोग यंग लोग हैं, हम अपनी ज़िंदगी कैसे गुजारते हैं, जिसको हम लाइफ स्टाइल कहते हैं, तर्ज़ ज़िंदगी क्या है. तो जब तक हम खुद रोल मॉडल नहीं बनेंगे पेशेंट्स के लिए, तो पेशेंट्स भी शायद हमारी बात को उतना सीरियसली नहीं लेंगे जितना कि उनको लेना चाहिए. और आई थिंक आजकल हर एक के पास आईफोन है, उसके अंदर एक ऐप है जिसको हेल्थ ऐप कहते हैं, वो शायद हम यूज़ नहीं करते. तो उसको टर्न ऑन कर लें तो अननोइंगली हमारे स्टेप्स को रिकॉर्ड करती रहती है. जैसे डॉक्टर नाले ने कहा कि 10,000 स्टेप्स, 5,000 to 7,000 स्टेप्स भी अननोइंगली अगर आप अभी भी खोलेंगे, रात को आपको खोलेंगे, इंटर्न्स तो शायद 10,000 क्लॉक करते होंगे. बट आई थिंक कि ये चीज़ें जो हैं, जो प्रिवेंशन के अंदर जो है, आई थिंक दोज आर क्रूशल. तो आई थिंक जैसे ने कहा कि NICVD सामने हमने रिसेंटली, आप जैसे डॉक्टर मरीम ने कहा, यंग लोगों को जो स्ट्रोक्स हैं, एंड आई थिंक दिस इज़ वेरी वेरी इंपॉर्टेंट, टेक केयर ऑफ आवर ओन हेल्थ. बाकी तो खैर आपने सभी सुन लिया, एंड आई रियली अप्रिशिएट डॉक्टर बास इधर आगे हैं टू फर्दर टॉक अबाउट, माशाल्लाह ही इज़ आल्सो द फोरफ्रंट ऑफ एवरीथिंग. थैंक यू.
I have one question for Dr. Ali. It may be my misconception or something like this. आपने एक concept बताया differentiated filler mismatch का. मेरा अपना concept शायद गलत है, वो ये है कि इफ़ यू हैव डिफरेंट रिस्ट्रिक्शन ऑन MRI स्टडी इट करस्पॉन्ड्स टू कोर इन्फॉर्म. ऐसा नहीं है. You mean if you have different restriction, you can refer that patient for intervention. It is not core infarct. अगर फिलेयर ठीक है तो फिर उसको हम इन्फॉर्क्ट काउंट नहीं करेंगे. If you have different restriction. देखिए फिलेयर may be normal in first 6 hours.
इंफार्क्शन है बट रिवर्सिबल है.
फिर इन्फॉर्क्शन नहीं है, फिर पेनम्ब्रा है. तो फिर आप उसको इन्फॉर्क्ट नहीं कहेंगे डिफरेंट रिस्ट्रिक्शन को.
पर से तो वो स्कीमिया है सॉर्ट ऑफ
दिस इज वेरी इंपॉर्टेंट.
बट जो भी इसको सपोर्ट करेगा बट ये दिस इज असली 100% नहीं होता सर. मगर अगर फ्लेयर में भी डेवलप नहीं हुआ है ना तो बहुत सारी स्टडीज ऐसी आई वो कहते हैं कि अभी भी चांस है कि ये सेल्वेजेबल है. और अगर फ्लेयर भी आ जाता है ना तो ये बैड साइन है. ठीक है, अब ये कोर हो गया, अब ये अपनी बस नहीं.
ये मेरे कैंडिडेट्स के लिए, मेरे लिए भी लर्निंग हो सकती है कि इफ़ आई गेट समथिंग डिफरेंट रिस्ट्रिक्शन एंड MC डिस्ट्रीब्यूशन सुपीरियर ट्रंक इंफीरियर ट्रंक, शायद मेरा जहन ये हो कि इट इज़ इरिवर्सिबल. डिफरेंट रिस्ट्रिक्शन आ गई है, कहीं अब इसको भगाने की ज़रूरत नहीं है, भेजने की एकदम. डिफरेंट रिस्ट्रिक्शन के बाद रिवर्सिबल उसको पेनम्ब्रा हम कह रहे हैं, सेल्वेजेबल है.
It takes about 6 hours for
So
the flare to
different-
become abnormal.
I mean different restriction does not correspond to core infarct.
No.
Diffusion restriction is largely ischemic.
Okay. It could be penumbra, it could be infarct.
It's reversible. A lot of times TIA patient diffusion restriction 24 hours there is no diffusion restriction.
ये जो आपने 6 hours का कट ऑफ यूज़ किया है, is that supported by literature or can't we go on to 24 hours if there is a mismatch? तो UK तो UK के अंदर हाँ तो 24 hours पे कई सालों से आई थिंक UK में वो दे डोंट अलाउ मोर देन 6 hours. वो NHS सिस्टम है.
क्राइटेरिया देखेंगे ना जिसमें आपको बिल्कुल मैकेनिकल थ्रोम्बेक्टमी का फायदा होता है 6 hours एंड देन वंस 6 hours की विंडो आउट हो जाती है देन वी डू सम फर्दर इमेजिंग लाइक परफ्यूजन कर लें, MR करके देख लें कि मिसमैच आ रहा है. तो फिर आपको पेनम्ब्रा और कोर में डिफरेंशिएट करना पड़ता है.
But once you do that, the gains from intervention up to 24 hours are similar to the first 6 hours, provided you have the core and penumbra mismatch.
mismatch and role of collaterals. तो सर अब ये खाली उसमें एक साइड करें, अब हम collaterals देख रहे हैं. If there are good collaterals, ये patient salvageable. And there are many factors. और फिर ये टाइम की तरफ तो बहुत सारी हर ग्रुप अपनी अलग गाइडलाइन, हर इंस्टीट्यूट अपनी अलग गाइडलाइन.
इसका मतलब है कि वी हैव वन न्यू प्रोटोकॉल व्हाट वी प्रैक्टिस बिकॉज ऑफ फाइनेंशियल कंस्ट्रेंट, एक NMC. मुझे नहीं पता ज़्यादा दिन वो कह रहे हैं कि एक्यूट सेटिंग में मुझे सिर्फ ऑनली डिफरेंट वेटेड सीक्वेंस दे दो. वी डू इट बिकॉज ऑफ फाइनेंशियल कंस्ट्रेंट. एक आदमी आ गया विद एक्यूट फोकल डेफिसिट और वो कह रहा है कि आई कांट अफोर्ड 20,000, 15,000, 30,000. हम कहते हैं 5,000 में हमें सिर्फ स्ट्रोक में आप डिफरेंट वेटेड सीक्वेंस देते हैं. इसका मतलब है वी आर गोइंग टू मिस सो मेनी थिंग्स विद सिंगल प्रोटोकॉल. हम उसको कभी भी ये काउंट ना करें कि वो कोर इन्फार्क्ट है.
Yes, sir, that depends on the window period. If the patient
Within
has
6 hours.
1.5
Within
window,
6 hours.
If there is a doubt regarding whether stroke or not, regarding the diagnosis, and then you can perhaps in that case that might make some sense that you and diffusion will get a measure to see whether it's a stroke or not. Perhaps that might be looking at.
Actually, the diffusion we are like
Do you practice this protocol in Riyadi only different weighted?
और ये हमें थोड़ा टाइम लगा इस प्रोटोकॉल को करने में. जैसे मैंने आपको एग्जांपल दी, एक यंग पेशेंट था कोविड के दिनों में 2021 में और जिसको हमने रिवर्स किया बट वही MR की ही वजह से उसका टाइम डिले. सो अब हमने बहुत स्ट्रिक्टली किया कि अगर इस्केमिक स्ट्रोक आ रहा है बट समटाइम्स ये चीज़ें चेंज हो जाती हैं. नए फिजिशियंस आ जाते हैं जो MR की स्ट्रिक्ट करते हैं तो ये हो जाता है. मैं बार बार ER को और जो हमारे स्ट्रोक टीम से हमसे ये बात करनी पड़ती है कि CT एंजियोग्राफी is a way to move forward, especially जब आपके पास 24/7 स्ट्रोक इंटरवेंशन की सहूलत मौजूद है. अब सर इशू ये है कि MRI is the most sensitive modality for acute ischemia. तो MRI का एक रोल है जहाँ पे इतना आपको पता करना है अगर कि इसको acute ischemia हुआ है या नहीं हुआ, वो तो काम MRI कर देगा जैसे आपने राइट डिफरेंट. बट एक्यूट सेटिंग में जब आपने ये सोचना है कि इसको हमने रिवर्स करना है इन दैट केस पर वो डिफ्यूजन का एमआर इंफीरियर हो जाता है। जैसे डॉक्टर नाम खुदा ने कहा, जो मैंने शुरू में भी एक चीज़ थोड़ी सी दिखाई थी, अगर आपको पता है कि पेशेंट उसको 24 घंटे गुजर चुके हैं कि अब उसको इंफार्क्ट हुआ है, और आपने सर ये पता करना है कि इसको इंफार्क्ट हुआ है या इंसेफ्लाइटिस हुआ है या कुछ और हेमरेज हुआ है, देन द डिफ्यूजन इज ओके, आपने डिफ्यूजन करा लिया, पता चल जाएगा इस्कीमिक स्ट्रोक है, एंड देन आप रिहेबिलिटेशन पे चले जाएंगे। मगर जहाँ एक्टिव इंटरवेंशन की विंडो है और आपने एक्टिव इंटरवेंशन करना है, देन द बेस्ट डू द सीटी सीजन एंजियोग्राफी एंड देन आइदर रेफर फॉर एनएससी में तो वैसे ज़्यादा हो सकता है क्योंकि उनके पास सारी चीज़ें हैं, they can do mechanical thrombectomy है।
But what's the rationale for doing fusion MRI?
When you are confused about diagnosis, whether acute deficit is stroke related or something else, they just go for diffusion restriction. वो कहते हैं हमें diffusion weighted sequence दे दो सिर्फ. At least it would give you different. It is a stroke. It is vascular event.
सर मैंने अपने स्ट्रोक स्क्रीनिंग में ना डिफ्यूजन के साथ फिर भी फ्लेयर रखा हुआ है।
This is very important. मैं यही चाह रहा हूँ कि हम ये सजेस्ट करें कि आपने फ्लेयर सीक्वेंस लाइकली लेना है तो clear whether it is there is mismatch or not.
I would just like to add regarding the practice in UK, because I do stroke neurology over there as well. So they do extended window from thrombectomies up to 24 hours, like I've practiced in East Yorkshire, and but that is with rapid AI software. So we have the patient comes in extended window after 6 hours. We do CT perfusion, CT angiogram, CT perfusion, a plain CT scan, CT angiogram, CT perfusion, and use the rapid AI software that gives us a complete volumetric analysis of the penumbra and the ischemic core, and then we decide about whether thrombectomy is needed or not.
This is the core CT.
Yeah, but we use it with the software.
So that's a good learning point you have, I think, mentioned. Whenever you're doing a screening sort of MRI for stroke, we need to imaging in 1.5 test or above machine, at least get a flare. But if you can add MRI as well, you can get a picture.
Thank you. We have lost the speaker.
So as the saying goes that prevention is better than cure. To have an informative talk regarding the prevention of stroke, I would like to invite Professor Dr. Mohammad Wase, who is a distinguished name in the field of neurology and is currently the Professor of Neurology at Aga Khan University Hospital and the President of Neurology Awareness and Research Foundation.
5 minutes. Assalamu alaikum. Bismillahirrahmanirrahim. Now you all know why stroke has to be prevented. Because once stroke happens, there is a lot of death and disability. Pakistan का जो data है, we have 40% mortality within 30 days of stroke. 40% mortality. और जो 60% बच जाते हैं, so there is a huge disability. So we still are not able to treat stroke well, so we cannot prevent a lot of mortality and morbidity. We still could reduce the burden of stroke. Now burden is again still very high, it's growing, that's the problem. For prevention there are 4 major important risk factors. First, number 1 and single most important risk factor is hypertension. So blood pressure control is the key, and this is the key for all cardiovascular diseases. So if you want to prevent stroke, पाकिस्तान की population में 45 से above की जितनी population है उसमें close to 40% they have high blood pressure. So high blood pressure की screening is must for everyone. For nurses, even for residents, we should make sure that we screen everyone for hypertension, and if they have high blood pressure, we treat them effectively, means control their blood pressure. So that's like number 1 intervention. We are not doing it very well across the country, but at least we have to start somewhere if we want to start want to prevent stroke. The second most important risk factor for stroke is actually environment and air pollution. So all the recent studies have shown that environment or air pollution is the second most important risk factor for stroke and other neurological diseases. And if the AQI level, which is air quality index, goes more than 100, which is kind of in Karachi is almost out of 360 days, 300 days, AQI is more than 100. Some days it's like 200 or 250, something like that. So if the AQI goes more than 100, that it increases the risk of stroke 20 to 30%, and if it goes beyond 200, then it increases the risk of 100%. So there is good data suggesting that AQI goes up, you have increased number of stroke patients and number of MI patients in the emergency room, and increased number of mortality because of this high AQI. And there is good data that if you are able to reduce the AQI, you decrease the number of admission and number of mortality both because of reducing the air quality index or improving the air quality index. So this is the second most important intervention. Now brain is the most affected organ related to environment as compared to any other organ. So the neurology community, they have to speak up and they have to come forward for this environment and air pollution issue. This is very important for our patients and our diseases and overall for population health and everything. So this is the second most important factor, but most of the time even the neurology residents and trainees, they don't know about this important risk factor, which has been recently very important risk factor. So this is the second risk factor most important in Pakistan and across the globe, especially in low and middle income countries. The third most important risk factor in Pakistan is actually tobacco, which is huge. Like we cannot imagine how strong tobacco is in Pakistan. But I live in Gulshan Iqbal. So from Nipa to Millennium Charongi, it's only 1 kilometer. And there are 6 vaping shops on that 1 kilometer strips. So common among college students, school students, vaping is so popular. If you just interview go to any college interview, about 20-30% boys and girls, they are vaping. So very common. So smoking is very common, vaping is going up, gutka is going up in the very low income countries, so in the low income population. So unless you are able to control this tobacco, you cannot control cardiovascular diseases and you cannot prevent the stroke. So this is something you have to actively ask people. People don't ask. Even I have seen patients, they have never been asked that do you smoke, do you use gutka, do you use vaping or not. And if they use, write it on your prescription. The top thing on your prescription, before you write S card or before you write anything, you have to write that you have to stop smoking if you want to prevent secondary or primary stroke. So this is something you have to be very aggressive and very active, and you have to make a way to convince people that they have to quit this tobacco habit. Like in our country, more than 12 years old, 24% population use one or the other kind of tobacco. अभी सोचे कि कितनी बड़ी आबादी है, कोई ना कोई टोबैको इस्तेमाल कर रहा है, पूरे गांव टोबैको इस्तेमाल कर रहे हैं. अभी हमारे AKU की टीम ने सर्वे किया था, पूरे गांव में गए, कोई 230 लोग थे, सब के सब टोबैको लेते थे, कोई एक बंदा भी नहीं था टोबैको इस्तेमाल नहीं करता. वहाँ तो खैर चलो एक गुर्बत की एक वजह कि लोग अपने बच्चों को टोबैको देते हैं कि चलो भाई बच्चे भूख नहीं खाने नहीं मांगेंगे, उससे भूख ख़त्म हो जाती है. लेकिन ये भी एक तरीके का एक जुल्म है. लेकिन बात यह है कि इतना टोबैको हमारे यहाँ है, इसके ऊपर वी आर नॉट एक्टिव. मतलब हम मरीज़ों से पूछते नहीं हैं, हम उनको समझाते नहीं हैं, हम उनको रोकने की कोशिश नहीं करते हैं कि आप सिगरेट छोड़ें, आप तंबाकू छोड़ें. तो सिर्फ प्रिस्क्रिप्शन लिखने से तो स्ट्रोक कम नहीं होगा. तो आई थिंक दीज आर 3 most important risk factors which we have to work. The other ones which are getting bigger and bigger is diabetes. Now diabetes अच्छी बात ये है कि वो सारे लोग स्क्रीन हो जाते हैं, और डायबिटीज़ का खौफ इतना है कि लोग डायबिटीज़ जिनको हो जाता है वो दवाइयाँ वगैरह ले लेते हैं. तो डायबिटीज़ को कंट्रोल करना निस्बतन आसान काम है. डिसलिपिडीमिया इज़ ऑल्सो अनदर वेरी इंपॉर्टेंट रिस्क फैक्टर. हमारे जितनी स्टडीज़ हुई हैं AKU में और पाकिस्तान में स्ट्रोक डेटाबेस की, 75% जो स्ट्रोक के मरीज़ आते हैं उनमें डिसलिपिडीमिया होता है. तो इट मीन डिसलिपिडीमिया इज़ क्वाइट प्रेवलेंट इन अवर कंट्री ना. 25% पॉपुलेशन इज़ डिसलिपिडीमिक और इवन मोर. और द लास्ट वन इज़ ओबेसिटी, और जो कि पाकिस्तान में अभी भी काफ़ी ज़्यादा है. ख़ासतौर पे जो एफ्लुएंट पॉपुलेशन है उसमें पाकिस्तान में ओबेसिटी 25% पॉपुलेशन है, यानी BMI मोर देन 30-35. आप स्कूल्स में कॉलेजेस में चले जाएं, यू विल सी अ लॉट ऑफ पीपल विद हाई बॉडी मॉस इंडेक्स. तो दिस इज़ ऑल्सो समथिंग यू हैव टू काइंड ऑफ पॉइंट आउट. अभी हमारे बेशतर डॉक्टर्स ना BMI नोट नहीं करते, ना वो देखते हैं कि पेशेंट को ओबेसिटी है या मॉर्बिड ओबेसिटी है या नहीं है. और दूसरे इसकी ट्रीटमेंट करने की ज़रूरत है. नाउ देयर इज़ गुड ट्रीटमेंट टू कंट्रोल द ओबेसिटी. यू हैव इंजेक्टेबल्स, यू हैव ओरल मेडिकेशंस, और डाइट कंट्रोल तो है ही है. लेकिन ओबेसिटी इज़ ए वेरी स्ट्रॉन्ग रिस्क फैक्टर फॉर कार्डियोवैस्कुलर डिजीजेस. तो अभी ये जो 6 रिस्क फैक्टर्स हैं, अगर इनको हम सिर्फ 10% भी कम करने में कामयाब हो जाए ना, यू कैन रिड्यूस द स्ट्रोक बर्डन 30%. यानी 30% स्ट्रोक बर्डन कम हो जाएगा. अभी हमारे पाकिस्तान में एवरेज 1000 लोगों को फालिज होता है और एवरेज 400 लोग मरते हैं फालिज से ना. तो आप समझें इसका 30% आप कम कर सकते हैं सिर्फ अपनी रिस्क फैक्टर इंटरवेंशन के ज़रिए, जो आप किसी और तरीके से इसको आप कम नहीं कर सकते, चाहे आप मज़ीद 50 स्ट्रोक यूनिट बना लें और 50 थ्रम्बेक्टमी सेंटर बना लें और 100 जगहों पे TPA शुरू कर दें, फिर भी आप इतना बर्डन कम नहीं कर सकते जितना आप इस प्राइमरी प्रिवेंशन के ज़रिए कर सकते हैं। तो एट दिस डे वर्ल्ड इज रिलेटेड वर्ल्ड स्ट्रोक डे, आई थिंक WHO समझती है कि जो सबसे अहम चीज़ है जो लो एंड मिडिल इनकम कंट्रीज़ में की जा सकती है वो स्ट्रोक प्रिवेंशन है, जो सबसे बड़ा फोकस होना चाहिए। समहाउ हमारा फोकस चेंज हो गया। अभी मेरी कार्डियोलॉजी वाले से बात होती है, डॉक्टर खाबर काज़मी हमारे दोस्त हैं, बड़े अच्छे NICVD में होते हैं, वो कहते हैं हमारी पूरी कार्डियोलॉजी की कॉन्फ्रेंस होती है 3 दिन की, उसमें एक लेक्चर प्रिवेंशन का नहीं होता, यानी 20 मिनट प्रिवेंशन के नहीं होते। वो जो पूरे 3 दिन होते हैं वो सिर्फ रिकैनलाइजेशन के ऊपर होते हैं कि किसी तरह जो है ना थ्रम्बेक्टमी की जाए, उसकी जो है ना वेसल्स खोली जाए, तो वो चलिए दैट्स स्टिल इम्पॉर्टेंट, लेकिन आप पूरी दुनिया आपकी वो तो नहीं है ना। तो इसलिए जो इंटरवेंशन वाला पार्ट है इट्स इम्पॉर्टेंट, यू हैव टू नो, यू हैव टू लर्न, यू हैव टू प्रैक्टिस। लेकिन जो इम्पॉर्टेंट पार्ट है जो हम सबको हर वक्त प्रैक्टिस करना चाहिए और जो हमें अच्छी तरह आना चाहिए वो स्ट्रोक प्रिवेंशन है। मतलब नो मैटर हाउ गुड वी आर in improving the tertiary care centers, लेकिन still we have to work on primary prevention of stroke, secondary prevention of stroke। secondary prevention में भी मैं आपको बताऊँ सिर्फ एक चीज़, atrial fibrillation। इतने मरीज हमारे पास AFib के आते हैं, never on anticoagulation। मतलब आप कहीं दुनिया में जाएं, इट्स ए क्राइम कि आपके पेशेंट को रेट कंट्रोल AFib है, atrial fibrillation है 6 महीने से 1 साल से, द पेशेंट इज़ नॉट ऑन एंटीकोगुलेशन और कोई वजह नहीं है कि क्यों नहीं है, पेशेंट कम्स विद स्ट्रोक। सो वाई दे आर नॉट एन एंटीकोगुलेशन, दिस इज़ द बिग क्वेश्चन। लेकिन इसका मतलब कोई डॉक्टर ने देखा होगा, किसी डॉक्टर ने लिखा होगा, दे डिड नॉट थिंक कि इसको एंटीकोगुलेशन की ज़रूरत है। तो अभी ये सेकेंडरी और प्राइमरी प्रिवेंशन में अगर आपने AFib को एंटीकोगुलेट नहीं किया हुआ है तो व्हाट्स द पॉइंट ऑफ योर प्रैक्टिस, मतलब व्हाट आर यू प्रैक्टिसिंग देन, कि आप अगर इतने मोटे मोटे स्ट्रोक भी प्रिवेंट नहीं कर रहे हैं तो फिर व्हाट काइंड ऑफ मेडिसिन यू आर प्रैक्टिसिंग ना। तो दैट्स ए की क्वेश्चन वी शुड कंसिडर। इसका टारगेट कोई ये नहीं कि कोई एक बंदा है, हम सब इसके अंदर बाज़ औक़ात इसके अंदर होते हैं कि वी डोंट पे अटेंशन टू थिंग्स, लेकिन दीज आर थिंग्स विच वी हैव टू पे अटेंशन एंड दिस इज़ द थिंग विच वी आर, इफ़ वी पे अटेंशन थोड़ी बहुत भी ना, I think we could make a lot of difference. So this is, I think, my message, take home message, that you have to focus on prevention for every single patient, and not only patient, मेरे साथ तो जो patient के family members आते हैं, मैं तो उनको भी साथ साथ ही होते हैं ना, तो इसलिए इसकी भी काउंसलिंग की ज़रूरत है। थैंक यू वेरी मच।
We are now heading towards the end of our session today. At last but not the least, we would like to conclude our seminar by a vote of thanks. For that, I would like to request our Head of Department Neurology Ward JPMC and the Vice President of Pakistan Society of Neurology, Professor Dr. Khalid Sheikh, to share a few words with us.
Thank you very much, Dr. Nadir Ali Sayyed and Dr. Shahid Mustafa, for being with us. You are our distinguished guests and you are with us as chair and co-chair of the session. I also want to give vote of thanks to all the speakers, organizers and participants, and I want to take all these names one by one, like Dr. Abdul Malik, Dr. Maryam Javed, Dr. Iname Khuda, Dr. Muhammad Ali, Dr. Nabila Sumro, as well as Dr. Wase for being with us for their informative talks. And it was honor that Dr. Malik offered me to hold this session in JPMC. He told me you are running largest public sector facility in the city and you have newly built neurology department, but you are not paying attention towards these academic activities. You are lagging behind. I told him we are having very much shortage of staff. We are so much, dealing with so large number of patients that we cannot spare time to be part of these large scale activities. But with help of Dr. Malik and all you distinguished guests for being with us, hopefully we will be holding these activities in future with your help. I am again thankful to all of you for being with us. Thank you very much.